morning, everyone. On behalf of Adley Oncology, I would like to welcome guest speaker of today's webinar, Professor Dr. Jasmina Ahluwalia, Speaker Professor Dr. M.B. Agarwal sir, Chief Guest Dr. Bhavin Shah, Discussants Dr. Asha Shah, Dr. M. Joseph John, Dr. Satish Kumar, Dr. Harsha Prasad, Dr. Amrita Saraf, Dr. Hamza Dalal, Dr. Bipin Kulkarni, Dr. Rucha Patil, Dr. Jasmita Das, Dr. Ankit Mohite, Dr. Nisarg Thakkar, Dr. Mona Vijayaran, and Dr. Rajat Jain. Before we commence the webinar, I would like to present you a small corporate video of 2 minutes. So, Nirav, can you run the video, please? Thank you, Nirav. Here I would like to mention that just to ensure the highest quality drugs at affordable prices reaches to your patients, all our drugs are backward integrated. So the API as well as the formulation both are in-house. And Adley is the only company in India who does that. Now to commence the event, I would like to invite our most respected M.B. Agarwal sir, please. Thank you very much.
Thank you, Mr. Ashutosh Shukla. So good morning to all the colleagues and friends from India. Good afternoon, good evening to others from various countries who have logged in. Today's lectures are on Willebrand disease, its diagnosis and management. And the speakers are Professor Jasmina Ahluwalia from PGI Chandigarh and myself. This webinar is brought to you by Mumbai Hematology Group. It is supported by Adley Oncology and managed by Mice Ideas. I thank Mr. Ashutosh Shukla and the team from Adley Oncology, Mr. Rajesh Sharma and the team from Mice Ideas, the Executive Committee of Mumbai Hematology Group, our chief guest of the day, Dr. Bhavin Shah, oncologist from Ahmedabad, our guest speaker, Professor Jasmina Ahluwalia from PGI Chandigarh, all our discussants who are themselves eminent hemostasis specialists, hematopathologists, or clinical hematologists. You participant for sparing your Sunday. Coming Saturday, that is 7th of May, in the evening, 7 p.m., Dr. Rajani Priya Yedla is our guest speaker. She is from Visakhapatnam. And she wants to speak to us on acute promyelocytic leukemia from highly fatal to highly curable disease. The next day morning, Sunday, 8th May at 11:30 a.m., we have Dr. Shiv Shankar, who is a clinical nutritionist and dietitian from Tata Memorial Hospital, Mumbai, speaking on nutrition in cancer patients. Now, 8th May is World Thalassemia Day. And at that occasion, in the afternoon and going up to late evening, we have Challenges in Thalassemia 2022, which is a 6-hour-long webinar with 8 international guest speakers, virtually who is who in the field of thalassemia, beginning at 3:15 p.m. and ending by 9:30 p.m. Today, we have very important personalities as our discussants, as shown in this slide. To introduce them, We have Dr. Asha Shah from Nanavati Hospital, Mumbai. Dr. Joseph John from CMC, Ludhiana. Dr. Satish Kumar from Manipal Hospital, Bangalore. Dr. Harsha Prasad from Kasturba Medical College Hospital, Manipal University, Mangaluru. Dr. Amrita Saraf from Sir Gangaram Hospital, New Delhi. Dr. Hamza Yusuf Dalal from Fortis Group of Hospitals, Mumbai. Dr. Bipin Kulkarni from NIIH ICMR, Mumbai. Dr. Rucha Patil from NIIH ICMR, Mumbai. Dr. Aniket Mohite from Jahangir Hospital, Pune. Dr. Nisarg Thakkar from Wockhardt Hospital, Rajkot. Dr. Mona Vijayaran from AIIMS, New Delhi. Dr. Rajat Jain from Sahyadri Super Speciality Hospital, Pune. Now it's time to introduce our special guest of the day. And I'm indeed honored and privileged by presence of my friend Dr. Bhavin Shah from Ahmedabad. Dr. Bhavin Shah is well known in the field of medical oncology and hematology in this country. To complete the formalities, he is a director and consultant medical oncologist hematologist at HOC Vedanta, Ahmedabad. He is the founder member of HOC Vedanta, which has a chain of daycare clinics with 13 medical oncologists and 4 hematopathologists taking care of patients with cancers and hematological disorders. He did graduation, post-graduation from MP Shah Medical College, Jamnagar, followed by his DM in medical oncology from GCRI Ahmedabad. His keen areas of interest include management of hematolymphoid malignancies. He also loves to treat refractory anemia and cytopenias. He is principal investigator of multiple phase 2-3 clinical trials in the field of hematological malignancies. Dr. Bhavin Shah, we are really privileged by your kind acceptance of this invitation to inaugurate our today's webinar and give some words of wisdom. Over to Dr. Bhavin Shah.
Good morning, everyone. Am I audible?
Yes, Bhavin.
Yeah. Thank you, Dr. Agarwal, for giving me this opportunity for becoming a guest speaker for this webinar. Initially, I was reluctant at first because I am neither a teacher or an academician, but then I thought I would share a few pieces of advice that have shaped my clinical journey with my younger colleagues. The first advice I got on very first day in my residency in internal medicine from my professor of medicine. He insisted that whenever you see the patient, take a clinical history and do a physical examination, at that time you have to keep a differential diagnosis in your mind. On the basis of that, you have to investigate the patient, and if by 72 hours, if you don't reach to a diagnosis, you have better refer the patient to a specialist. And I'm talking when I was doing my residency in internal medicine. He also told on the same day that your prescription should be your face. So don't prescribe any unnecessary drugs like vitamin B12 or a folic acid or a multivitamin, antacid, proton pump inhibitor, unless it is required. Even after 25 years of this advice, I always see my patients with this principle. The second advice that I got during my specialization in oncology was from my teacher in medical oncology. He always insists that whenever the diagnosis is rare or there is an uncommon presentation of a common disorder, get the diagnosis review. He also insists to review the case from fresh if the biology of the or a behavior of the disease is uncommon. You always remain suspicious and open to review the diagnosis and management if the natural history of the disease does not match. And it is quite rewarding, not only in our patients, but even in a patients who come for a second opinion. After completion of my residency in medical oncology, we were discussing the opportunities in private practice. During that time, my professor in oncology explained me that clinical practice is like an ocean. Daily, many boats will enter the ocean to catch the fish. Everyone will be blessed with the fish that is proportionate to their efforts. Whoever would dive deeper would benefit more. But none of the fishermen come back empty handed. And this is true for clinical practice. In this sea of patience, one must just keep diving. And this dilemma occurs to many young patients, especially if they want to settle in a big city where already there are many consultants of same specialties are there, and many of them have a very good practice. So there is always fear that whether we will survive or not. But I think in this ocean of patience, everybody will catch the fish as per their capabilities. So he also suggested not to invest much or borrow money in early years of practice. If something goes wrong, it will pressurize yourself to take shortcuts. And I think it is very relevant advice from my teachers. We all know that hematology and oncology are dynamic medical subspecialties. With the better understanding of molecular pathology and precision medicine, the treatment algorithm is changing rapidly. And with that, we must remain updated to deliver the state of art treatment to all our patients. And we don't have any greater example than Dr. M.B. Agarwal or Dr. Pankaj Shah for this. To all my younger colleagues, I'm sure that you all are blessed with the base skill and knowledge. But to becoming a better clinician, you should be honest, caring, and empathetic to your patients. I think these advices has given a tremendous value to my practice in last 25 years. And I wish that it will also help you to decide somewhere. With that, I ask Dr. Agrawal to inaugurate the scientific session. Thank you, Dr. Agrawal.
Thank you, Dr. Bhavin Shah, for those wonderful words, tremendous advices. I'm sure not only the juniors, everyone would benefit from those golden words. What you've learned and you've practiced for 25, 30 years, you've shared with all of us. And I'm grateful to you for sparing us Sunday morning and being with us and giving a thoughtful talk to inaugurate our webinar. Thank you so much.
Thank you, sir. Thank you.
We now move on to the second part, and that is our Sunday quiz. As usual, we'll be giving you the quiz, and the answer has to be emailed to this email ID put over here, mbagarwal1@gmail.com. Whoever is the first correct answer will be the winner, and of course, we will give you the names of all those who forward the correct answer, including the order in which we received it. So we go on to now the Sunday quiz. And this time, this Sunday quiz is on the subject that you will be lectured for the next 1 hour. So we are going to give you 9 statements regarding von Willebrand disease itself. All the statements are correct, except one statement. So pick up the wrong statement. And there's a number to that statement, 1, 2, 3, up to 9. So that number you will be emailing to mbagarwal1@gmail.com. And the winner will be fastest finger first. So be ready. These are the 9 statements regarding von Willebrand disease. 1. Von Willebrand disease has no geographical, ethnic, or racial prevalence. Number 2. Normal plasma von Willebrand factor is 50 to 200 international units per dl. Individuals with von Willebrand disease of 30 to 50 are called low von Willebrand factor levels, and those who have less than 30 units are labeled as von Willebrand disease. Statement 3. Von Willebrand factor ristosetting cofactor activity, VWF GP1BR, VWF GP1BM are functional activities assays. Number 4, in clinics, female patients of von Willebrand disease outnumber male patients. 5. Type 1 von Willebrand disease accounts for 75% of cases in the clinics. 6. Type 2N is inherited as an autosomal dominant disease. 7. Type 2M has normal multimers. 8. The human VWF gene is on chromosome 12 and it was cloned in 1985. 9. The genetic test is useful to diagnose type 2, to discriminate VWD from mild hemophilia A, as well as to diagnose platelet type von Willebrand disease. So you got these 9 statements. I'm going to keep this slide on for a few moments. One of this statement is wrong, and email the number on the left side, that number 1 to 9 anyone, to mbagarwal1@gmail.com. Fastest finger first will be the winner, and we will give you the names of all those who forwarded correct answer in the order in which we received that. Fine, so we'll move on now. And it's now time to go to the main part of this webinar. And we are privileged by the kind presence of our guest speaker, Professor Jasmina Ahluwalia from PGI Chandigarh. It's my pleasure to introduce her. She has been our regular speaker in person and online for many, many years. And we are blessed by the education she has been imparting to us in this field. She is Professor of Hematology at the PGI Chandigarh. She received her medical degree from AFMC Pune, India. She served as a medical officer in the army for 5 years. After that, she did her MD pathology from PGI Chandigarh. She stayed on to join the Department of Hematology in PGI as a faculty from 2000 onwards. She's continued to work in the field of coagulation ever since then. She has over 150 publications to her credit. Her interests are in the lab diagnosis and workup of patients of both bleeding and thrombotic disorders. Today, she's going to speak to us on von Willebrand disease, its diagnosis. Well, thank you, and over to Professor Jasmina.
Thank you, sir. I'm going to share my screen. So I hope you can see my screen now.
Yes.
And I'm audible?
You're audible.
Okay. So thank you, Dr. Agarwal and the Mumbai Hematology Group for this opportunity to speak on the diagnosis of von Willebrand disease. And sorry about that. So the von Willebrand disease is one of the commonest bleeding disorders, but I would admit, sitting in a lab, that it is one of the most difficult to diagnose. Currently, there has recently been an update from the American Society of Hematology, the ISTH, the National Hemophilia Federation, and the World Federation of Hemophilia in early 2021, where the guidelines on the diagnosis of von Willebrand disease have been elucidated. This guideline is a very helpful guideline, and I would suggest that everybody hearing this webinar and who's interested in the diagnosis of this should go through these, because they answer a number of questions. So coming to the general considerations, von Willebrand disease is a bleeding disorder which is associated with a quantitative or a qualitative defect in the von Willebrand factor molecule. This may be inherited or this may be acquired, where we call it the acquired von Willebrand syndrome. It is a very common disorder, and the prevalence in population studies is to the tune of 1.3%. But somehow we don't see so many of them in our hospitals, and there the prevalence in hospital referrals is just 1 in 10,000. Probably we are grossly underdiagnosing this disorder in our country because of a lack of awareness in our patients, lack of awareness in our doctors, the lack of expertise in diagnosis, the lack of facilities, and of course the difficulties inherent in the von Willebrand factor molecule itself. Von Willebrand factor molecule is a big protein synthesized in the endothelial cells. It is synthesized as monomers, then it forms dimers, and finally multimers, which are stored in the Weibel-Palade bodies of the endothelium, and from there they are secreted into the plasma. Now, before we go any further, let's see what are the functions of von Willebrand factor in hemostasis. So, the von Willebrand factor is circulating in the plasma as a coiled molecule, and at the site of injury where the endothelium is disrupted and the subendothelial collagen is exposed, by means of its collagen binding domain, it attaches itself to the collagen. This results in straightening out of the von Willebrand factor molecule, and now its epitope to recognize platelets is exposed. So then begins its next function, which is adhesion to platelets. So the platelet now gets anchored to the collagen through this as well as its own collagen receptor. Once this happens, there are signals sent to the center of the platelet which activate it. These platelets tend to aggregate, they cross-link with fibrinogen and form the primary clot. So in addition to its properties of adhesion to collagen and platelet adhesion, von Willebrand factor acts as a carrier molecule for factor VIII. And in the absence of von Willebrand factor molecule, factor VIII would degenerate very fast. So if we see this cartoon to the right, if there is a deficiency in the von Willebrand factor molecule, in the collagen binding part of it, then we would expect a bleeding disorder to ensue. And so also we would expect this to occur if there is a problem in the platelet binding site for the von Willebrand factor molecule. Over and above this, if there's a deficiency of the molecule itself, then again there would be a problem in the hemostasis. So the diagnosis of von Willebrand disease rests on three important pillars. One is the personal history of bleeding in the patient. Two is the characteristic laboratory abnormalities that are expected. And the third is a family history of bleeding, because as we will see a little later, there are a number of environmental modifiers of von Willebrand factor levels, which makes early diagnosis very difficult. So if there are family members available and they can be tested, this really helps in establishing von Willebrand disease in that family. So what is the clinical presentation? Most patients would present with epistaxis or bleeding after tooth extraction, with ecchymosis or hematomas, and women would come to the clinics with menorrhagia and be detected with heavy bleeding at delivery. GI hemorrhage is also known to occur in von Willebrand disease. So as you can see from these, there is nothing really very specific about the clinical presentation of von Willebrand disorder as compared to other bleeding disorders. So in the current guidelines, there is what is recommended now is that the first clinician who's seeing these patients should take the clinical history in the form of a structured questionnaire called a bleeding assessment tool, so that not only are these bleeding symptoms taken into cognizance, their severity is also assessed, and thereafter a bleeding score is assigned, and based on the bleeding score, this primary care healthcare professional can then decide whether to investigate further or not. So if it is positive, then the patient can be sent for further testing. So this BAT, or the bleeding assessment tool, may not be required in situations where there is intermediate probability of von Willebrand disease occurring. That is, patients who have a history of bleeding or who have abnormal tests or are being seen by a hematologist. So there, this can be done away with, though it may help to document the kind of bleeding present in these patients. And the BAT score is really not required when there is a family history of a family member with diagnosed von Willebrand disease. So what does the lab do in testing for von Willebrand disease? First, we are required to confirm the diagnosis. Then we need to sub-characterize the type of von Willebrand disease, because the treatment depends on the kind of von Willebrand disease there is, the subtype, and we shall soon be seeing which ones those are. And once the treatment starts, it's important to monitor this therapy, especially when factor replacement is being done. But that said, we must remember that lab tests do not necessarily match the in vivo situation and may not correlate with bleeding. So all of us working in the coagulation lab are very well aware that there are these 6 basic screening tests: prothrombin time, APTT, fibrinogen, platelet count, thrombin time, and bleeding time, which are used to screen for bleeding disorders. In von Willebrand disease, surprisingly, all of these routine screening tests may be normal. At times, if the factor VIII carrying capacity is impaired, there may be a prolongation of the APTT. And in one type of von Willebrand disease, that is the type 2B, there may be a fall in platelet count. So other than that, we may find nothing if we go hunting for von Willebrand disease with these basic screening tests. So what screening tests should we then use for von Willebrand disease? The most important thing is that the clinician referring this must make a mention that he wants us in the lab to screen for von Willebrand disease. The 4 common tests which we would need to make a good diagnosis are the von Willebrand factor antigen assay. Then one test to look at its platelet binding capacity, which could be the ristocytin cofactor activity, or the von Willebrand factor GP1BR assay, or the von Willebrand factor GP1BM assay. We'll just come to these in a minute. The factor VIII assay to tell us how much is the factor VIII level, because that has some bearing in the therapy. And the other functional assay is the von Willebrand factor collagen binding assay, which looks at its collagen binding ability. So if we look at the algorithm below and we've gone a step lower, we can see that according to the current guidelines, once we decide to investigate, we need to do at least the antigen and the activity assay and the factor VIII. So we need to have these tests available if we want to screen for von Willebrand disease. So coming to the first test, which is the von Willebrand factor antigen assay, this is an immunological test, and it can be done easily by ELISA, which could be manual or automated. The ELISA is very sensitive and has a very low limit of detection, but the problem is you have to do batch mode testing, and it usually has a delayed turnaround time. So this has been overcome in a large number of analyzers now that we use by the latex immunoassays. These are automated. You can test a single sample. These are faster, but there's a trade-off, and there is a lower sensitivity as compared to the ELISAs. People who have rheumatoid arthritis, rheumatoid factor positive may get falsely high levels of von Willebrand antigen. A further improvement is the chemiluminescence immunoassay, which is more expensive and is cartridge-based, but is much faster and has a very low limit of detection to the tune of 0.1 international units per deciliter. So this has a very important role in the detection of severe von Willebrand disease, where we need to show that there is no measurable von Willebrand factor. Now, how do we say a person has von Willebrand disease? If the factor VIII antigen levels are less than 30, then this person does have von Willebrand disease. If the person has a von Willebrand factor antigen level between 30 and 50, he may possibly have a von Willebrand disease, or these might just be low von Willebrand factor levels. If the person has bleeding, then it's wise to investigate this person for a possible von Willebrand disease with the screening test and the others. But you have to remember that when we undertake this, we must have our own population reference ranges. And I must mention that in India, it has been reported in a couple of papers that the von Willebrand factor levels are higher as compared to what is being described in the Western population. We have no reference ranges in children, so this becomes a bit of a headache. But the good thing is that von Willebrand factor antigen levels are supposed to be normal at birth. So a fall in the von Willebrand factor antigen levels at birth can tell us that there is a von Willebrand disease. As a test, it's not a good standalone test for type 2 von Willebrand disease, because that's a qualitative defect. And here, the antigen levels may be normal, but the activity may be compromised. And in type 3 von Willebrand disease, we need to have unmeasurable levels. And this is a very big challenge for all testing platforms, because what is actually unmeasurable in one becomes less than 5 international units, whereas on a CLIA, it may go down to as less as 0.1 international units per deciliter. Now, the first activity assay that we have is the ristocytin cofactor activity assay. While circulating in the blood, von Willebrand factor binds to platelets by opening out under shear force. At the site of injury, there is a change in shear, so the molecule opens out. But how do we do this in a test tube? So this happens by adding an antibiotic called ristocytin, which induces a conformational change in von Willebrand factor that allows it to bind to its receptor on platelets. Now, this is a functional assay, platelet agglutination procedure using the patient's plasma and ristocytin on normal or fixed platelets. It can be visualized by aggregometry, and low ristocytin cofactor activity is seen in type 2A, 2B, 2M, and type 3 von Willebrand disease. Now, the conventional assay, which depends on aggregometry, needs a lot of expertise. It has a very high inter-assay variability, has very poor reproducibility, and has a very low limit of this, a very high limit, lower limit of detection. So it becomes a challenge to diagnose severe von Willebrand disease by this assay alone. And the current guidelines now of 2021 recommend that one suggests that the newer assays should be used in place of the conventional assays. So what are these newer assays? One of them is the von Willebrand factor glycoprotein 1b R. R stands for recombinant. Now here what we are doing is, instead of using platelets, we now have latex particles. These are coated with antibodies. These antibodies bind to a recombinant GP1b molecule. So this now acts, this whole latex particle with this GP1b acts like the platelet. When the patient's plasma is added and it contains von Willebrand factor, that opens up in the presence of ristocytin, which is also present in the reagent, and this binds to this latex particle. The more binding there is an increase in absorbance, and that indicates the amount of the ristocytin activity in the sample. So this is automated. It has a very fast turnaround time. It's not very much affected by lipemia, hemolysis, or jaundice. It has very good reproducibility. But a diagnostic issue associated with this test is that in some patients who have a polymorphism in the von Willebrand factor, the test may be abnormal, but they may not actually have von Willebrand disease. So we may be misled into making a wrong diagnosis. And easy to see, but if it is used as a standalone test, we are likely to miss the collagen binding defects in patients with von Willebrand disease. Now coming to the next test, which is the von Willebrand factor collagen binding assay. This is essentially like any other ELISA. There is a plate on which collagen is bound. The patient's von Willebrand factor binds to collagen by its specific site. And this is then labeled with a horseradish peroxidase antibody, which acts on a substrate. After washings, the amount of color that is produced is directly proportionate to the amount of von Willebrand factor bound to the collagen. So this gives us the collagen binding activity. The procedural steps are very much like an ELISA, but the test is not actually free of problems, because the type of collagen which is used, 1 or 3, may have produced different results. Type 3 collagen binds very strongly, type 1 binds too weakly. But the good thing about this test is it acts like a surrogate for the von Willebrand factor multiple analysis. So let me share one case with you to see how this diagnostic algorithm goes. An 11-year-old male who came with petechiae and ecchymosis since early age, with prolonged bleeding following trauma since 1 year of age, had 2 or 3 episodes of epistaxis 2 years back and 1 episode of hematuria, was sent for investigation for hemophilia. And here in his investigations, we can see that the APTTs were long. So a mixing study was done, which suggested a factor VIII deficiency. The factor VIII assay confirmed this to be moderate hemophilia A, and so we were ready with the diagnosis and released the report. A sample of this patient stored for the von Willebrand factor antigen and activity assay. We had just acquired a new coagulation analyzer at that time, which was offering these tests, and we were storing most of our samples just to get a random idea how this test was working. And lo and behold, after 1 month, when that test was run, we found that he had unmeasurable levels of both the antigen and the activity. So what looked like a moderate hemophilia A was actually a severe von Willebrand disease type 3. So it's important to exclude von Willebrand disease in all cases of moderate and mild hemophilia, since severe von Willebrand disease can have low factor VIII levels lying between 1 and 10%. So this is a simple, straightforward case. Other than type 3, there are a number of other subtypes. And let's look at the phenotypic classification. The classification actually rests on a quantitative or a qualitative defect. If there is a qualitative defect, it is type 1 or type 3. In type 1, there is a partial deficiency of von Willebrand factor, whereas in type 3, there is a severe deficiency. Type 2 constitutes the qualitative von Willebrand factor defects. These may be a defect in its binding to the platelet receptor, so those are 2A, B, and N, or a defect in its factor VIII binding site, which is type 2N or type 2N romantic. Now, in both type 2A and type 2N, there is a defective binding to the platelets, but in type 2A, there is an absence of high molecular weight multimers seen on gel electrophoresis, whereas in type 2N, the defect is there, but the multimers are intact. Type 2b forms an interesting variant where there is an increased affinity of the 1 Willebrand factor molecule for its receptor, the platelet glycoprotein 1b. So this high affinity 1 Willebrand factor molecule binds to its platelet receptor and gets removed from the circulation, resulting in low VWF levels in the plasma and therefore creating a deficiency state. This is very type 2b 1 Willebrand disease can be just resembling almost completely the platelet type 1 Willebrand disease, where instead of a defective 1 Willebrand factor molecule, the GP1B receptor of the platelet has a gain of function mutation, which makes it behave in just the same way. These cannot be differentiated either clinically or by many of the lab tests. In addition, there is now one type C 1 Willebrand disease, which is characterized by an increased clearance of 1 Willebrand factor from the plasma. So these tests would, the screening test would give us a diagnosis of 1 Willebrand disease, but to put them in these further subcategories, we need further tests. So very obviously, to differentiate between type 2A and 2N, we need a multimer analysis to see whether the multimers are absent or present. For type 2B, showing the high affinity, we have the ribostocitrin-induced platelet aggregation test. For type 2N, we need the 1 Willebrand factor 8 binding assay. And for type 1, including the ones which are associated with high clearance, we need a desmopressin challenge test, which is the only in vivo test we have. And we also need the 1 Willebrand factor propeptide assay, which gives us an idea if there is acquired 1 Willebrand syndrome or a severe type 1 Willebrand disease where there is increased clearance. Thankfully, genetic analysis is not required in all cases of 1 Willebrand disease, but they would be required in type 3, especially where genetic counseling and antenatal testing needs to be done. And in type 2, for diagnosis, confirming the diagnosis of some of the subtypes, but it's really not recommended in type 1 Willebrand disease. So using the data from these tests, we can use some ratios to get an idea how we can differentiate type 1 from type 2 1 Willebrand disease. So essentially, the ratio contains the functional assay value in the numerator and the antigen assay value in the denominator. So it can be with GP1BR in the numerator, or the activity, or the collagen binding, or the factor VIII binding in the numerator. If both of these, the activity and the antigen, are proportionately decreased, then this is a concordant ratio and usually signifies type 1 Willebrand disease. Whereas if the activity is much less as compared to the antigen, then this becomes discordant and it is an indicator that this is type 2 1 Willebrand disease. And this is essentially used to differentiate between type 1 and type 2, these ratios. So you can see this in the algorithm which is shown in the latest guideline, that if the ratio is greater than 0.7, then it is type 1, and if it is less than 0.7, then it is type 2. There was some debate on what cutoff should be used, but now currently the guidelines recommend 0.7 as a good cutoff of the ratio. Before I move from this slide, I'd like to emphasize that these ratios don't work for severe type 3 1 Willebrand disease, because here the 1 Willebrand factor antigen levels are virtually unmeasured. So let us look at another case. There's a 12-year-old boy who was born with history of ecchymosis and epistaxis. He had family history and had a grandmother who had suffered from frequent epistaxis. His test showed a prolongation of the APTT, and factor VIII assay showed a mild deficiency. We can see that the 1 Willebrand factor antigen and activity assays were also reduced, but we can see that all three of them, the 8 assay, the antigen, and the GP1BR, are proportionately reduced. So when we calculate the ratio, we get a ratio of 1. This is more than 7. And according to our algorithm, this is where we are. So we are looking at a type 1 1 Willebrand disease. So these patients would benefit from desmopressin, because desmopressin causes release of 1 Willebrand factor stored in the endothelial cells. And but before that, it's important to do a desmopressin challenge test. In this test, this is the only test which is done in vivo. 3 micrograms per kilogram of desmopressin is infused in saline over 30 minutes. And at the end of 1 hour and 4 hours, we are required to measure the factor VIII, the 1 Willebrand factor antigen, and recough. A complete response or a good response to the DDAVP is associated with a 2-fold increase in the factor VIII or 1 Willebrand factor value, and they must also be above 50%. Whereas in a partial response, there may be either of these two. That is, either there is a 2-fold increase or a greater than 30% increase in the activity or factor VIII. if the 4R value of 1 Willebrand factor is more than 30% lower than what its 1R value was, then this signifies a type 1C 1 Willebrand disease. And in fact, this is the recommended test now for type 1C 1 Willebrand disease. So let us look at another case. We have a 5-year-old girl who came with ecchymosis on and off since 2 years. There was no history of transfusions and no family history of bleeding. She was being investigated for bleeding despite a platelet count of 69,000. So the pediatricians were suspecting either a platelet function defect or 1 Willebrand disease. Her investigations confirmed the low platelet count and the APTT was prolonged. The mixing study showed a factor deficiency with low factor VIII levels. The 1 Willebrand factor antigen was reduced, but the activity was reduced even more. And so the ratio was less than 0.7. And this fits with a type 2 1 Willebrand disease. So this is where we are in our algorithm. If the ratio is less than 0.7, then we're looking at a type 2 1 Willebrand disease. Now in type 2, we know we have to look for type 2A, B, and N. So one way to distinguish them would be to do a 1 Willebrand factor multimer assay. The 1 Willebrand, the patient's plasma is run on a gel, electrophoretic gel, and by the distribution of multimers, we can make out which of the multimers are missing. So in this picture, if the gel on the lane 1 shows a normal control, the high molecular weight multimers are towards the upper end, whereas the low weight moleculars are at the lower end. In lane 2, there is a severe deficiency, type 3 1 Willebrand disease, no multimers are seen. But in 3, 4, and 5, there is an absence of the high molecular weight multimers. So these could be type 2A 1 Willebrand disease. Though it looks very nice here, this is a very technically challenging test. It takes nearly a week to complete, and it is needed to differentiate between type 2A and 2N. So we need not do this test for type 1 or type 3 1 Willebrand disease, and it's certainly not recommended upfront. Now, to diagnose type 2B 1 Willebrand disease, there is one lab test, which is the ristocetin-induced platelet aggregation, or the REPA. We just discussed the RECOF, in which we looked at varying concentrations of the patient's plasma to fixed concentrations of ristocetin. But in this test, we look at varying doses of ristocetin against a fixed concentration of the patient's plasma and platelets. So in a normal individual, at low dose ristocetin of 0.5 or 0.6, there is no aggregation and we get a flat curve. Most of the normal people would start to show aggregation at 0.8 milligrams per ml, and by 1.2 to 1.5, almost everybody would have a good brisk aggregation with ristocetin. If we get an aggregation in the low dose, this is suggestive of a type 2B 1 Willebrand disease or a platelet type 1 Willebrand disease. Both of them can have the same result. Now, running 5 tests in a small child's plasma sample, which is very precious, is very difficult. So most labs, including ours, have abbreviated this REPA, and we do just 2 concentrations, 0.5 shown in this blue line and 1.2 shown in this black line. In a normal individual, the blue line is flat and the black line shows a robust response. So in this patient, when we did it, we saw that the blue line shows aggregation, which means she showed hyperaggregability with low dose ristocetin. Now, this could suggest either a platelet type 1 Willebrand disease or a type 2B 1 Willebrand disease. So one way to distinguish it is to do a mixing test, in which we would once use the patient's platelets and the other time a patient's plasma along with normal plasma or normal platelets and see which one is defective. So when we repeated this test at 0.5 milligrams per ml ristocetin with using the patient's plasma, we can see that we now get the normal pattern, which means that the patient's plasma was normal. But when we did it with the patient's platelets, we got the abnormal wave back again, indicating that probably the patient's platelets were abnormal. So from this mixing study, we surmised that this patient had a platelet type 1 Willebrand disease. So this means there's a defect on GP1B alpha receptor of the patient's platelets. The 1 Willebrand factor was supposed to be normal. Now this needs to be confirmed by genetic testing. But before we go to that, let us quickly have a look at the 1 Willebrand factor gene, its domains and mutations. So this is a huge gene sitting on chromosome 12, and I hope you answered all of you answered that right in Dr. Agarwal's quiz. It has 52 exons and pretty big in size. And one of the problems is that from exon 23 to 34, there is almost 90% sequence homology with chromosome 21. So this can be a big problem for people who are working in genetics, and they have to design their primers very carefully. This gene codes for this protein, which has a mature part and a propeptide part. And as we said before, this propeptide gets split off before the after the 1 Willebrand factor is secreted into the plasma and can be detected by the propeptide assay. The protein then folds itself into some domains which have specific functions. For instance, the multimerization is largely located in the D3 domain. Dimerization is towards the carboxy terminal. Factor VIII binding is associated with the D' D3 domain, whereas the collagen binding activity is in the A1 and A3 domains. So for some of the types of 1 Willebrand disease, the mutations are located in very specific domains, and so testing for very specific exons can give you the result. For instance, for type 2B and 2N, just sequencing exon 28 will give you the answers. But if you're looking at a case of type 2A, the whole gene will need to be sequenced to get an answer. So coming back to the patient we were talking about, in her case, when we did the sequencing, we found at that time we did not have the platelet GP1BR primers, but we had asked for the exon 28 primers of 1 Willebrand disease. So if you recall, I had said that we thought that this was a platelet type 1 Willebrand disease, so we expected a normal result on sequencing exon 28 of this patient. But what we saw was there was a C to T change in the nucleotide, resulting in a change in the protein from arginine to tryptophan. Now, this is a very well described mutation in type 2B 1 Willebrand disease. So, what we had labeled as a type 2, platelet type 1 Willebrand disease in this girl was actually the type 2 1 Willebrand disease on genetic testing. So this is now very well recognized in the current guidelines, and if we look at how we are supposed to investigate type 2B 1 Willebrand disease, they suggest genetic testing upfront if available. If it's positive for the type 2B 1 Willebrand disease variants, we diagnose type 2B 1 Willebrand disease. If the genetic testing is negative, then we go to the read path, and if that is positive, we need to look at GP1B variants on the platelet, because here the genetic testing has not revealed a mutation in the 1 Willebrand factor molecule. And if it's negative, then it is to be called a type 2A 1 Willebrand disease. So there is a sea change, and all of us in India will now have to think, if we want to diagnose PWD correctly, we'll need to have these genetic testing facilities available fast. Now coming to the next type 2 Normandy, this is an autosomal recessive kind of 1 Willebrand disease. Most of the type 2s are autosomal dominant, type 1 is autosomal dominant, and type 3 is autosomal recessive. So here, as we had discussed before, there is a defect in the binding of 1 Willebrand factor to factor VIII. So the factor VIII levels are low, but the 1 Willebrand factor antigen levels may be normal or low. So the ratio we would expect then to have to be low. The factor VIII is low in these patients because it tends to decay very fast. The antigen may or may not be low, but is definitely not as low as the factor. So this can, if you look at this, it can resemble a mild hemophilia A or a carrier of hemophilia. So in these patients, we need to remember that most of us use the one-stage factor VIII assay. This has been found in many studies to overestimate the amount of factor VIII present in the patient. So we need to be aware of this, and a chromogenic assay may be more reliable if we are trying to pick up a type 2 in Normandy. The 1 Willebrand factor VIII, 1 Willebrand factor VIII binding assay is the test which will be required to confirm this diagnosis in the lab. And this, thankfully, it's a very reliable assay, unlike the histostigin-induced platelet aggregation. Now, if we look at the current algorithm, either of the two approaches is correct. If you want to go for genetic testing, you can go for genetic testing upfront. If it is positive for a type 2 in 1 Willebrand variant, you can diagnose type 2 in 1 Willebrand disease. If it's negative, then you diagnose something else. If it is positive for a novel variant which has not been described, then you need to do the binding assay. And if the binding assay is positive, then you are looking at a new variant of type 2N, which you can easily report. If it's negative, then you're looking at any other type of 1 Willebrand disease. If you want to, however, start with the binding assay, then if the binding assay is abnormal, you should go for genetic testing. If it's positive, you have the diagnosis of a type 2 and 1 Willebrand disease. If the genetic testing is negative, then we need to consider other subtypes or even hemophilia A. Or if you get a normal 1 Willebrand factor binding assay, you do the factor VIII level. If the factor VIII level is low, then you're probably looking at a hemophilia A or a cardio. If it's normal, then you need to consider von Willebrand, other types of von Willebrand disease. Before anybody in the lab signs out a report on von Willebrand disease, it is important to remember that there are a number of modifiers of the levels of von Willebrand factor in our blood. Von Willebrand factor increases with age. It is lower in patients with blood group O because of a faster clearance. It increases in acute phase with stress, exercise, changes with menstrual cycle phases, increases in pregnancy, and of course increases with desmopressin. Hypothyroidism, which again is a very common situation in our country, is associated with low von Willebrand factor levels. So we need to keep this in our mind and ask for history or look at the test to keep, make sure that these factors are not interfering with our assays. And to make matters worse, there are some genetic polymorphisms associated with clearance or exocytosis of the von Willebrand factor molecule, which will alter the VWF levels, but will give us no mutation in the VWF gene itself. So these can be really big confounders. So very obviously, we would need an algorithmic approach to diagnose von Willebrand disease, and this is one such algorithm from Australia, which is a very busy slide, but I personally think it is a very useful one because it gives you a reflex test for what you have to do next. And as you can see, instead of starting with the basic coagulation screen, we start with the von Willebrand assay panel, including the antigen, the collagen binding assay, the ristocytin cofactor binding assay, and the factor VIII C antigen. If these levels are very low, the antigen levels are very low, we would confirm that the activity and collagen binding are also very low, and if these are unmeasurable, then of course you're looking at a type 3 von Willebrand disease. If the binding to factor VIII is abnormal, if the factor VIII is factor VIII and level versus the antigen level is low, then you might be looking at a type 2N. In this case, you need to do the binding assay. If, however, the antigen is low and both the ratios of the ristocytin and collagen binding to antigen are normal, that is greater than 0.7, then you're looking at a type 1 von Willebrand disease. If, however, the antigen is very low, then it is a severe type 1 von Willebrand disease. Otherwise, it's a mild or moderate one. If both the ratios are low, then and the antigen is low, then we are looking at a type 2A or 2B, and for 2B we need to do the RIPA. Whereas if the collagen binding ratio is normal and the ristocytin cofactor ratio is low, then this is a sort of a surrogate marker for type 2N von Willebrand disease. We need to repeat all tests if possible in a baseline state to be sure that the values that we have got are truly representative of the patient's baseline status. And wherever there is a clinical suspicion, these tests need to be repeated. And this is the guideline in toto. We discussed this in little bits and parts, which is now has appeared in the 2021 guideline. So wouldn't it be nice if we could do all the tests in one ELISA plate? So there was a recent publication, not a little older, in 2016, where people have tried to put the antigen, the activity, ristocytin cofactor binding, factor VIII all on the same ELISA plate and have reported good results, but still is not currently available. So all of you here, I'm sure, have realized that accurate assignment of von Willebrand type and subtype is, a very difficult exercise, and it's like a torture for junior trainees. But I can say it's a torture for all of us who have to sign out reports. But all the same, it's very important because it can influence treatment decisions and understanding of inheritance patterns in a family. Assigning von Willebrand phenotype at present requires so many different assays, and many of these are cumbersome, they're difficult to standardize, and are available only in very specialized laboratories. So as a result, repeat testing becomes a norm, and many times it takes a very long time to reach a definite diagnosis. And at times, I'm sure we fail to even give this diagnosis to our patients. So a stepwise approach is required in the diagnosis of von Willebrand disease in the lab. Repeat testing is recommended, and though most of the types of von Willebrand disease, we can sort of form an impression by the testing in the coagulation lab, genetic confirmation is a must with type 2N and type 2B von Willebrand disease. So all learning is teamwork, and I am absolutely grateful to the staff at the coagulation lab, my clinical colleagues in the pediatric hematology oncology clinic and the adult hematology clinic, as well as to our DM residents who have, sent cases to us, have asked us questions and made us think so that we reach the correct answers for our patients. Thank you.
Thank you, Professor Ahluwalia. Wonderful talk, great depth you have gone into. I'm sure that the people who have heard you today, their knowledge of von Willebrand disease diagnosis will be enriched and the patients will benefit. So before we come to the Q&A session with you, we've got two jobs to do. One, we are going to give the answer of the quiz and the winner's name as well as those who give the correct answer. And then we'll also have the talk on the treatment of von Willebrand disease. And then in the last part, we'll have the question and answer session. I'll just share my screen. So starting with the quiz that was asked, you were given 9 statements regarding von Willebrand disease, and you were to pick up the wrong statement and email its number. These were the 9 statements, and I'm not going to read them again. But what I'm going to tell you is the number 6 was the wrong one. The type 2N, like type 3, is an autosomal recessive inheritance. And what was mentioned was autosomal dominant. So this was the wrong statement. All other statements were correct. So what was expected from you is the correct answer as 6 by the email. So we got sort of correct answers. And this is from number 2 onwards, in the order in which we got them from 11:46 a.m. to 11:52. So in these 6 minutes, we got these answers. Dr. Christopher Liam, Dr. Mona Vijayaran, Dr. Satish Kumar, Dr. Akanksha Garg, Dr. Deepika Gupta, Dr. Sumit Mirk, Dr. Sasitha Suthianathan, Dr. Khai Teri, Dr. Jyoti Savne, Dr. Pujitha Reddy, Dr. Amit Khurana, Dr. Arun V.A., Dr. Radhika K.K., Dr. Sejal Kotwani, and Dr. Harsha Prasad. So congratulations to all of you. You gave the correct answer and pretty quickly. The job was done at 11:45, and within a minute to next few minutes, all of you sent the correct answer. The winner, that is fastest finger fast, is Dr. Ketan Modak. His reply came at 11:45. He has been an active participant of these webinars. He's DM resident from Department of Clinical Hematology, CMC Ludhiana. As per our records, it's possible that he has completed his DM and maybe faculty somewhere, but that's what our records say. We have his boss over here. He may tell us if he has completed and left. So congratulations, Dr. Ketan, and we will send you your prize amount. We move on now to the management of von Willebrand disease. So we're trying to put the pieces together and sort out this puzzle, which is a puzzle to me even at my age. It was way back, almost 100 years ago, 1926, when Eric Adolph von Willebrand suspected that a family of bleeders was not probably hemophilia, as there were males and females involved in 5 to 6 generations of 2 closely related families from an island. 100 years later, we know that von Willebrand disease is an extremely common genetic bleeding disorder. And unlike hemophilia, it is inherited in autosomal fashion, with majority being autosomal dominant. The diagnosis, you have been enriched in last 30 to 40 minutes very extensively. But as a clinician, we face this problem. And this article summarizes what we face. The so-called cryptogenic oozers and bruisers. So I'll read this for you. It's very interesting. Bleeding disorders with normal, borderline, or non-diagnostic coagulation tests represent a diagnostic challenge. And you and me see this in daily practice. Disorders of primary hemostasis may be evaluated by additional platelet function test modalities, not widely available. Platelet electron microscopy, extremely rarely available. Repeat von Willebrand testing, available, but specialized von Willebrand factor testing beyond the usual color, not widely available. Secondary hemostasis may be evaluated by coagulation factor assay, factor 13 assay, etc., which are available, and the disorders of fibrin clot stabilization. Fibrinolytic disorders are particularly difficult to diagnose with the current testing options. At the end of it, what happens? A good number of patients remain unclassified despite thorough testing. Most unclassified patients are fortunately mild bleeding phenotype. Many may have undiagnosed platelet function disorders, which we do not have an access to, not only in India, but even in the Western world. High throughput genetic testing using large gene panels for bleeding disorder may give you diagnosis for some of them in future, but more studies are needed. And this is a very recent publication. A logical lab workup in the context of clinical setting and a high level of expertise regarding test interpretation and limitations facilitates a diagnosis for as many patients as possible, and still you are left with this label of cryptogenic oozers and bruisers for many of them, unless you've got Dr. Professor Ahluwalia at your disposal to diagnose your cases. Now, 1 in 1,000 individuals have a bleeding disorder. That's something huge figure, isn't it? And most of them would not know that. And you may be one of them. So, the optimal diagnosis of von Willebrand disease first requires the suspicion. Because you just can't go on doing tests for every epistaxis, every menorrhagia, and every bruising. And when you have a significant suspicion, then of course you do a specific testing. And we just saw the difficulties of this testing. And understanding the available lab tests is even more difficult. If Dr. Jasmina Ahluwalia does all this package of tests and sends me without the conclusion, there can be difficulty for me in interpreting them. And this happens not only for diagnosing von Willebrand disease, not only for its subtyping, but also to then decide the appropriate treatment, which is my job this afternoon. You saw by now that von Willebrand factor does 2 jobs. In the primary hemostasis, it allows the platelet to interact with the damaged subendothelial collagen. And at the same time, for secondary hemostasis, it's a carrier for the factor 8. So if von Willebrand factor is not there, or if it's defective, you got platelets which can't work, and you have a drop in factor 8 level. And that's why all that we heard, type 1, type 3, type 2, A, B, M, and N, and including type 1C. And what's interesting is something in this slide. What it shows you is it's fine as far as the type 1, 2, and type 3 is concerned. You see something over here. That is low von Willebrand factor individuals. And what it tells you, that these are guys having factor level between 30 to 50. And the same slide shows you that the 50 and above, right up to 200, may be the normal people. So what are these people? 30 to 50. Are they patients of von Willebrand disease? Or they are not patients of von Willebrand disease. At the moment, in clinics, it's difficult, and therefore this subgroup has been labeled as not von Willebrand disease, but low von Willebrand factor people. Maybe the genetics will help you to differentiate. And if you can imagine, as was mentioned, with the aging, there is an increase in the factor level. So somebody who's got 40% von Willebrand factor, when he becomes 80-year-old, he may have 70% von Willebrand factor. The same thing is shown over here, that you've got this type 1 von Willebrand, type 3 von Willebrand, and low von Willebrand factor, where the level is 30 to 50. And one is not clear in the clinics whether these are patients or these are not patients. Von Willebrand disease, because of its peculiarity of mild bleeding disorder to severe bleeding disorder, can present at any age. An infant may be brought to you because type 3, and an 80-year-old man may bleed after prostatectomy because he's got a mild variant. Though it's an autosomal disease, in clinics, the females outnumber males. And the reason is very simple, that the female has a uterus. So clinical manifestations of this disease, by now you've understood that this could be something like failure of primary hemostasis or something like failure of secondary hemostasis. So you've got all this bruising and mucosal bleeding and menorrhagia, and you may also have skeletal-muscular bleeding and hemarthrosis, especially in type 3 and type 2N. Lab diagnosis, you have heard so extensively that this slide becomes very, very primitive slide in front of what you've heard. But I just want to concentrate on the first statement. Whom should you investigate? Because if you want to investigate for von Willebrand disease, you have to have an access to an excellent lab, and it requires significant amount of money. So every bruiser, every epistaxis, every menorrhagia to be investigated is a bad medicine. And therefore we have this BAT, the quantitative bleeding assessment tool. To learn this, to use it bedside, when the patient enters your clinic, takes little few minutes, but it's worth it than spending a large amount of money and time in doing these investigations. You just heard that age comes in the way, the blood group comes in the way, and the inflammatory status comes in the way. You become 70, 80-year-old, your factor goes up, your blood group O, your factor may be low, and von Willebrand factor is an acute phase reactant. So anything happens to you, trauma, infection, inflammation, malignancy, it goes up. And you saw the beautiful discussion on multimer analysis, not easily available once again to you and me. Not all lab can do this, but how beautifully it can dissect between the different types, which have a tremendous bearing when we come to the treatment. So in clinics, what we do, we like to at least divide our patients into mild, moderate, and severe. If you look at type 3, it's invariably severe. You look at type 1, it is there all over. And type 2 probably in between. If you look at the factor levels, the factor levels are very low, producing severe disease, and they are much better, producing a mild disease. Now let's discuss the management per se. So obviously in a genetic bleeder, what do? You replace the factor. Factor 8, factor 9, factor 13, whatever is the type of factor missing in your body, you replace that. In von Willebrand disease, you do that, and you do that with the help of 3 types of factor replacement: cryoprecipitate, plasma-derived concentrates, and this plasma-derived concentrate usually have factor 8 with it, and in the Western world, you may have even without factor 8, what is called very, very highly purified von Willebrand concentrate. And then in the Western world, you also have recombinant factor concentrate. So this is what you keep replacing, from cryoprecipitate to plasma-derived products to recombinant. But when you're talking about von Willebrand disease, there is another way, and which you heard in the last half an hour. You can induce production of your own von Willebrand factor and factor 8, and that is by this drug desmopressin, which you can't do in many other bleeding disorders of genetic origin. Now, when do you replace these factors? Most of us will do this on demand. Somebody is brought with the injury, is bleeding, and you want to arrest that bleeding, so that's on demand. And number of times we'll do this in a prophylactic fashion. That means the patient is not bleeding, but you want to prevent bleeding. Short-term prophylaxis is extremely common. A woman is going to deliver, you are going to do a CABG on somebody, you need to support that person because you don't want bleeding to take place. But long-term prophylaxis, as we commonly discuss in hemophilia, is something which is rarely done for von Willebrand disease. We'll come back to this a bit later on. After considering replacement of the factors, what next do you do? Another important aspect of treatment is support therapy. And the first and the most important support therapy is with the help of hemostatic agents. And the hemostatic agents are usually the antifibrinolytic agents. And there's no better example than von Willebrand disease, where we exploit these antifibrinolytic agents extensively, especially tranexamic acid. And then it's a disease, as we said, of woman because she has a uterus. And because she has a uterus, she can have menorrhagia and menorrhagia and menorrhagia. And therefore, you've got to manage a woman for her menorrhagia. And we do that with the help of hormonal therapy. So you've got oral contraceptive pills, and we'll discuss what is Mirena. And lastly, your patients may benefit from something which you will not easily think of, that is not plasma-derived factors, not recombinant factors, but the platelet transfusion. Remember that the platelet produces factor VIII and von Willebrand factor and stores von Willebrand factor. And of course, you want to vaccinate all your patients against hepatitis A and hepatitis B. And then von Willebrand disease produces specific situations. And top is menorrhagia because that's something the woman keeps coming to you repeatedly till she achieves menopause. And because once again, woman has to become mother, there are issues related to pregnancy, there are issues related to delivery, and there are issues related to puerperium. So this is something, these two are very specific to von Willebrand disease, which we don't discuss with hemophilia A and hemophilia B. And then, of course, the things which we discuss for all. Somebody is undergoing surgery, somebody is undergoing dental intervention. GI bleeding is another very peculiar phenomenon von Willebrand disease. And you may be able to treat somebody very, very well, efficiently, and this bleeding can make you a failure, even as an expert hemostatic person. And then your guys, because they've got mild to moderate disease, they live for a normal lifespan, and they get diseases where you have to give them antiplatelet agents because they've undergone stenting. You have to give them anticoagulant therapy because they've undergone valve replacement, and all that has to be done despite the patient being a bleeder. Not with that frequency, but patients of von Willebrand disease, especially type 3, can develop alloantibodies, and that can often be the end of the story for that particular person. And often the treatment has to be individualized. I shouldn't say often, almost always the treatment has to be individualized. And like hemophilia, probably you can close this chapter with a word on gene therapy, though it may not happen in my life. There is a subject of acquired von Willebrand disease. One of these webinars, we had discussed one case of acquired von Willebrand disease secondary to SLE. And time will not permit to go into the depth of it, but that can happen like acquired hemophilia, acquired von Willebrand disease. It is more heterogeneous than acquired hemophilia because it is due to a number of mechanisms. Now we come to a little in-depth discussion. That was the background which a student has to understand in managing von Willebrand disease. So to have the treatment strategy, you must know the subtype. You must know the baseline factor VIII and von Willebrand factor levels. You must know the response to DDAVP trial. You should know what is the type of bleeding your patient is facing, what is the nature of surgery the patient is undergoing, whether there is an inhibitor or not. Even if it is rare, you have to see for everybody, and whether there are any potential risks associated with the treatment that you are offering. Choice of the therapeutic products. So this is desmopressin. And this is another way desmopressin is administered, which is nasal spray. So in many patients with type 1 and some of type 2, desmopressin, which is a synthetic analog of vasopressin, can increase the production of von Willebrand factor from your own endothelium and can help you in achieving hemostasis. Now, this endogenous von Willebrand as well as factor VIII coming from the endothelium can produce substantial rise so that the bleeding can be arrested and can also be used in a prophylactic fashion. This drug can be administered intravenously, and that's the commonest route I do. Subcutaneously, which the patient can do himself or herself at home, and intranasally by the spray which I just showed you. The dose for both intravenous and subcutaneous is identical, 0.3 milligram per kg, and not to exceed 20 mg. While that for the intranasal is 150 milligram which is 1 spray, to 300 milligram, which is 2 spray, based on whether the patient is less than 50 kilo or more than 50 kilo. The subcutaneous and intravenous formulation can increase the level of von Willebrand factor 8 by about 3 times the baseline. And this happens within half an hour to 1 hour of its administration. You can repeat this drug twice a day or once a day. But you can do this only for about 2 to 3 days. After that, tachyphylaxis sets in and the drug will be ineffective because you have pulled out all the factor von Willebrand 8 that was present in the endothelium and platelets. Whenever effective and not contraindicated, we'll see that. And a big issue is if it's available to you. Then the treatment of choice is desmopressin or DDAVP. It's 1-D-amino, 8-D-arginine vasopressin. And the reason is that you don't want your patient to be exposed to blood products, because the next one we have is plasma-derived von Willebrand factor. Desmopressin, if you go by the type of von Willebrand disease, in type 3 is ineffective. So this less than 5% of patient, it's useless. When we talk about type 2B, it's contraindicated because it will lead to further worsening of thrombocytopenia, or it will induce thrombocytopenia, and also the therapeutic response is poor. 70% of von Willebrand patients, however, are type 1. And in type 1, desmopressin is very effective. In type 2A and type 2M, it has variable efficacy. And it is not used in type 2N because the factor 8 that you will produce, there is nothing to stabilize it. As a result of which patient will not have hemostasis. So in other words, this is a drug of choice for type 1, and you may be able to use it for some of type 2. It's not effective in the remaining type 2 and not effective at all for type 3 and contraindicated in 2B. Okay, that's the importance of knowing what type of von Willebrand disease your patient has. So this is a summary of this. Usually effective in type 1, totally ineffective in type 3, and so on in between. Now, you already heard about the DDAVP trial, which is to differentiate between type 1 from type C. But what's most important is if you are going to use desmopressin as a treatment for your patient, you should do a trial and see in every patient what happens. You may give it by IV route or subcutaneous route or intranasal route and then look at the level. Because this is an increment which is consistent for the whole life of the patient, you can do this one and divide your patients in where you will be able to use desmopressin and where not. So there were 2 determinants. One was the genetic type of von Willebrand disease. One is the response to the treatment, and both are something for lifelong. So you can divide all your patients into responsive or not responsive. So most of the data on this slide I have mentioned to you. I'll skip this. And yeah, this has got something more. So there are certain adverse effects. These are in the form of tachycardia, flushing, and headache. Usually they are mild and hence bearable. Because it's an antidiuretics, it can lead to waterlogging and in the bargain, hyponatremia. And this hyponatremia in very young children, especially under the age of 2 years, can create serious problem. And hence the drug is not used under the age of 2 years. And if it has to be given, you should monitor the electrolytes and fluid should be restricted. The drug is also not to be used if the patient has got active cardiovascular disease, is an epileptic. During pregnancy, if the woman has developed preeclampsia, and the type with 1C, because there will be no sustained increment in the von Willebrand factor. So this showed you the side effects, why children should not be used, who else it should not be used, why the fluid and the electrolyte monitoring is important. And the bad news is over here. The DDAVP injection has been temporarily discontinued by its manufacturer. And that's a huge problem, because there's a huge shortage of minerin in the market. What I used as a resident in hematology, as a practitioner when I was young, the easy availability of it made our job very, very easy, has become a very difficult modality of treatment because of its poor availability in India for last almost a decade. Now, those patients who are not candidate for DDAVP, you will be going to the factor replacement therapy, tranexamic acid, and for a woman, OC pills. These alternative treatment will be selected based on the type of bleeding and the relative efficacy of the treatment. Now, once you know the type, which is a permanent feature, and response to DDAVP, which is a permanent feature, you can draw a comprehensive care plan for each patient, which will be applicable for the whole of the rest of the life of that patient. So this has to be sort of, framed and kept. This plan will give you what product should be used, what dosage should be used, depending upon the severity of the bleeding disorder and the nature of surgery. Now let's look at the factor concentrates. So you got number of factor concentrates which are now licensed and are available in India. What you should look at is what is the ratio of factor 8 to von Willebrand activity, and what is the ratio of von Willebrand antigen to von Willebrand activity, and the contents with respect to the multimeric structure. Now, all these are usually given in the product data sheet when you buy a product, and the amount of VWF activity is printed on the each vial with each batch. So you have to look at that to calculate everything. Now, if there is an acute emergency or there is an emergency surgery, then you need to have a product that contains factor 8. Because if you give a highly purified von Willebrand factor, anyway that's not available in India, then it will take hours for that von Willebrand factor to stabilize the endogenous factor 8. So most of us will be using a product which is a combination of factor 8 and von Willebrand. When you give this product, overall the half-life of factor 8 is longer than that of von Willebrand. And when you keep doing this, you can reach a status where factor 8 level could go to 200 and 300%. If that happens, that person can develop VTE, that is thromboembolic phenomena. And this you have to be very careful. Cryoprecipitate. Now, many of us working in major institutions, in major cities may feel that that is, as I say, once upon a time, history. But that's not history. Unfortunately, a large number of patients of von Willebrand disease staying in remote part of India still have to be managed with cryoprecipitate. And in fact, even the making of cryoprecipitate is slowly disappearing, and they have to be treated with fresh frozen plasma, which is a pity. Now, this is the historical evolution of treatment of von Willebrand disease with factor replacement. Once we knew that what the von Willebrand disease is, the plasma and the plasma fraction, then the cryoprecipitate, then the pasteurized product having both von Willebrand factor and factor 8, then von Willebrand factor with low factor 8 activity, and the recombinant von Willebrand factor tried in animals, then in human beings, and then got FDA approval 7 years ago. So factor replacement therapy is needed in about 10 to 20% of patients. The source of von Willebrand factor should be known to you. Cryoprecipitate may have to be used when you are in remote places. If you're using factor 8 concentrate, you should know all these ratios. The intermediate purity product is the one which you and me use left and right. The high purity product are problematic. And for the Western world, of course, you've got some von Willebrand concentrates. How much do you give and how often do you give? So for major surgery, around 50 units per kg. And as the indications become minor and minor, you start reducing the dose that you give, 40, 20 to 30, and so on. It may be given once a day. It may be given even once every alternate day. Or it may be just one time, like dental extraction, or some bleeding control. Now, for delivery in the puerperium, you give higher amount, and this is given one day before the delivery or cesarean, and it is continued in the postpartum period for 3 to 5 days. Your target is that the drug level of factor 8C should be more than 50% till the healing is complete, which may be approximately 7 days, or in a minor surgery, 3 days, or for a dental extraction, 12 hours, for a spontaneous bleeding, 2 to 3 days, and for delivery, 3 to 4 days or more. This is a case of type 3, 47-year-old undergoing surgery for pseudotumor of right thigh, and you can look at the factor 8C level being raised to 50 and then gradually allowed to drop to 25 and 50. And these are the various concentrates available in the market. We have easy access to Alphanet from Grifols, and they keep stock of their other products like Fendi as well. So when this is not available, you can have Fendi and so on. So Grifol has been a regular supply of von Willebrand factor, that is factor 8 containing von Willebrand factor. And you also have other supplies. You have supply from Intas, you have from Reliance, and so on. And the last one, what you see in the list, is the recombinant factor, not available in India, the von Wendi. Worldwide, these are the various factors containing various ratios of von Willebrand factor to factor 8. The one that we use left and right is Alphanet from Grifols. So Grifols has been a big help, and that is Alphanet vial. Various strengths are available, 250, 500, 1000, 1500, and so on. Coit is another preparation again from the house of Grifol, which is easily available and can be used when Alphanet is not available. And that's von Wendi, the recombinant factor von Willebrand, not available to you and me in this part of the world. How do you monitor when you are giving this product to a bleeder or in a prophylactic fashion for the surgery? You may do APTT, you may do factor 8C, you may do bleeding time, you may do the functional assay. Bleeding time, of course, is not done in practice. It's very inconvenient to the patient. All of them have some kind of advantage, disadvantage. Some of them are widely available, convenient, and is practiced in small centers. Some of them are extremely good, but they're extremely sensitive, and they give you an idea about bleeding, like the functional assay and the factor 8, and that is what should be done in major center, and it's being practiced in major center. We leave the factors aside and move on to the hemostatic agents, tranexamic acid, a very, very loved baby by the hematologist. So this is a wonderful antifibrinolytic agent which is used liberally. I think hardly any patient worth talking about does not use it. It's given orally in the form of tablet. It can be used as mouthwash, and it can also be administered intravenously. It can be used as a sole treatment for mild cases of epistaxis, mild menorrhagia, or it can be given in combination with desmopressin or even factors. The beauty is it can be used during pregnancy. There's absolutely no contraindication and no risk to the fetus. For elective procedures, we give oral or IV in advance for it to become effective as an antifibrinolytic agent, which decreases the requirement of our factor. And there are others like aminocaproic acid, and you've got the sealants and the recombinant thrombin, but tranexamic acid is the most popular one. You can give it 3 times a day, 4 times a day, 500 mg, 1000 mg, 1500 mg, etc. Don't use it for the urinary tract bleeding like in hemophilia. We come to the management of specific situations. And most important proband for us is female von Willebrand disease. If you know how to handle a female von Willebrand disease, probably a champion of the bleeding disorders. So in a woman, besides factor replacement, you have the special role of hormonal therapy. In everybody, you've got a role of hemostatic substances. You have a woman undergoing surgery, and the commonest is vaginal delivery and the cesarean section. And remember, a woman has to be kept with a good hemoglobin. So sometimes she requires intravenous gram of FCM repeatedly. Menorrhagia is extremely common for the woman with von Willebrand disease, and use hemostatic agent, hormonal therapy, and sometimes you take help of your obstetric gynecologist and use surgery. So there are options and options available. The orally administered OC pill and tranexamic acid is the first line of therapy. If there is a poor response, you go to desmopressin, which can be administered by self. And next tool, which I told you I will talk about, is Mirena. What is Mirena? It's the pure progesterone IUD, intrauterine device. And this is used very commonly for a woman who has menorrhagia and who is not going for a baby. All these fields, then you take help of your gynecologist, and they can do thermal ablation of the uterine lining, and they can go right up to the hysterectomy. It all depends upon various factors. And this is what the Mirena looks like, a T-like structure which is inserted in the uterus and which leads to thrombosis of the blood vessels in the endometrium and prevents menorrhagia. The next part in a woman is the pregnancy. Pregnancy, delivery, and the puerperia. So you can use desmopressin, you can use intermediate or highly purified von Willebrand factor, and you can use tranexamic acid, and they can be used during pregnancy, during delivery, during puerperia. 50% of the fetuses will have a chance that they've got von Willebrand disease, and you must not forget that, especially during the delivery period. Management of von Willebrand disease during pregnancy is again based on its subtype. As far as the type 1 is concerned, fortunately, von Willebrand factor keeps rising with the progressive pregnancy and is in a hemostatic range even to have a normal delivery. This increment is variable in type 2. And in type 2B, a woman who didn't have thrombocytopenia may have thrombocytopenia during the second and third trimester of pregnancy. In type 3, nothing happens. No increment in von Willebrand factor or factor 8 takes place, and they invariably require support from outside, not only to prevent miscarriage in the first trimester, but also to conduct normal vaginal delivery or cesarean section, or to give them spinal anesthesia, epidural anesthesia. And this is what happens in the first, second, and the third trimester. First, second, and the third trimester, you can see how the levels go up, and this is factor 8. This is von Willebrand factor NTG. And then after the delivery, the levels drop. So delivery which went uneventful, or in a cesarean went uneventful, the woman can end up with postpartum hemorrhage. So desmopressin can be used in women without complications, especially if there is no preeclampsia. Be careful, the fetus can develop hyponatremia. Epidural anesthesia should be avoided in unpredictable type 2 and always in type 3 to be avoided. So all this I have mentioned to you. Yeah. Vacuum extraction, application of forceps, and fetal scalp monitoring should be totally avoided in the neonates who are likely to have reduced von Willebrand factor activity. And in type 3, as was mentioned by Dr. Jasmina, genetic testing and prenatal diagnosis can be offered, and we are fortunate enough in Mumbai to have ICMR NIH to do this for us. So this is the summary of managing a woman with pregnancy, delivery, and the puerperia. So this is a challenging issue. Multidisciplinary approach is required. Factors should be assessed in the first and the third trimester. The delivery, once again, has to be conducted by the team. Epidural anesthesia may be contraindicated in certain subtypes. The PPH has to be remembered and managed, rather prevented. etc., etc. And the neonate will be at risk, has to be remembered. And next 5 days after delivery have to be managed with tranexamic acid, desmopressin, or factor. And this is a beautiful publication, Pregnancy and Delivery in Women with von Willebrand disease. Surgery, including dentistry. Well, if you have understood how a delivery is to be conducted in the mother, you understood most of the things that are done in surgery. And you even do a CABG or a neurosurgery in patients of von Willebrand disease. The principles don't differ. Minor surgery, moderate surgery, major surgery, use of hemostatic agents like tranexamic acid, desmopressin, or factor concentrates, etc., etc. And this is a publication on perioperative management of patient with von Willebrand disease. You read this, your patient will not have any problem. And this is for patients who are at risk of thrombosis, because you don't want to just keep pushing and have factor VIII level of 300 and then have a DVT with pulmonary embolism. GI bleeding is a special issue, and I don't think I will have time to go into the detail. I just want to mention that every GI bleeding requires endoscopic evaluation because there can be local factors. And patients of von Willebrand disease develop angiodysplasia. And these local factors have to be managed besides replacing factors. Von Willebrand factor become adult and elderly, and they need antiplatelets and anticoagulants, and these must be offered to them with the help of tranexamic acid, AVP, or even factor replacement. This is a turning point in the life history of any bleeder, that is development of alloantibody, which commonly happens with type 3, and fortunately only in 5 to 10% of patients. And this is really a turning point because the management of this patient is very, very difficult. You have to go to recombinant factor 8, but that has got a very short half-life. You can use Novo 7, but it's extremely expensive. You can use FIBA, and that is fortunately available in this country, sometime at a lower rate. You can also use emicizumab, again expense, and then others. Immune tolerance very often is not effective in inhibitor development in von Willebrand disease. Dr. Jasmina told you about the platelet type of von Willebrand disease. She told you how this is diagnosed. I may just say that this is managed by giving platelets and not plasma, cryo, or factor concentrates. A word about long-term prophylactic therapy. So this is not a usual practice for most of the patient, but if you've got a type 3 von Willebrand disease, especially if he's getting hemarthrosis, or you've got a patient who's not type 3, but is distressed by severe epistaxis, or a woman is distressed by pronounced menorrhagia, then prophylactic therapy is justified. These are some details. You may give it once or twice in a week and so on. And these are some problems with prophylaxis, which are similar to hemophilia, nothing special. And this is an article about prophylaxis management of patients of von Willebrand disease last year. Severe von Willebrand disease is a special chapter and needs to be discussed at length when we can have time, because this is a patient who can die. Acquired von Willebrand is a different subject. Once again, there is a nice article 2 years ago in Hematologica. Very often these articles are not exactly addressing hematologists, but this article by Manushi is addressing hematologists. Large number of these patients have associated monoclonal gammopathy, or I can say that if you have picked up a monoclonal gammopathy, look out for presence of acquired von Willebrand disease. Various modalities exist to treat them, and one of them is to give continuous infusion of von Willebrand factor. And this is a flow chart how you manage acquired von Willebrand disease. Treat the underlying disease. If the patient has settled, it's all over. If there's no response, use DDAVP. If there's a good response, you stop there. If there's no response, then you look at whether there is monoclonal gammopathy, other underlying disorders, manage them with immunoglobulins, factor concentrates, depending upon the response, and you may be able to use DDAVP as well. Molecular diagnosis is important, and Dr. Jasmina already told you the details of it, so I'll skip it. For some of the conditions, it is extremely important, like type 3 for prenatal diagnosis, for type 2N and type 2B, whether it is confirmatory. It's of no benefit for type 2A, type 2M, and in 35% of patients of type One, you will not have any test available. Depending upon a particular group of patient, variable number of type 1 patient will not be picked up by genetic test. So I conclude my talk by saying that von Willebrand disease is the commonest hereditary bleeding disorder. 90% of the subjects have lab findings and they don't reach you in the clinic. And therefore, you don't have that figure of 1 in 100 if you are practicing hematologist. Majority with clinical symptoms have mild bleeder, and you can manage them very easily without too many expenses. Bleeding score is a beneficial way to decide which menorrhagia or which epistaxis patient should be investigated. Interpreters show the lab data should take the age, blood group, and the presence of inflammation into consideration. Hemostasis can be achieved easily in majority of the patient. And remember that thrombosis can occur if you push the level of factor 8 to very high levels. Well, thank you so much. I stop here, and now we will go to the Q&A session. I request all of you, if possible, to open your videos, and we will go both with the question from the audience as well as by raise hand sign over here. Questions on the diagnosis will be addressed by Dr. Jasmina, and I'll try, if I can, to answer the question on management. So we start with Rucha Patel.
So good afternoon. Hi, ma'am. The question is for you. So my question is, most of the type of 2N cases get misdiagnosed as mild hemophilia A because all the BWF related investigations are normal. So no laboratory does the factor VIII binding assays. We know that too as routine services. And the genetic test is the confirmatory test, meaning we have to do that. But even that is the last option which we use. So I just wanted to know that whether there is any kind of screening test like a recovery study or a T-half study, which could give at least an idea that this is not a mild hemophilia and maybe a von Willebrand 2N type, or any new research on this where a simple test could tell us rather than going directly for a genetic test.
That's a good question, Rucha, and very correctly, said. But what I would say is, if you look at the current guidelines, it's reasonably clear that the only two proper modalities available to us are the factor VIII binding and the genetics. Basically, what we need to do is probably improve our services. You're already doing a fabulous job by doing the molecular. I think all of us have to get into that game fast. Otherwise, we are going to be missing them. And what is the more worrying thing is that in all of our publications of Indian von Willebrand disease on the genetics, there are hardly any patients with type 2N. Whereas some of the European populations are showing larger proportion. Probably there must be some founder effect and something there, but I guess we are missing them.
We are missing them.
We are missing them. If they are just mild, we are going to continue missing them because they will not reach hospitals. The diagnosis is so lab-based now that, unless we get a good history and we can run all those tests, we are likely to miss them. So I'm not really aware of any one test which can act as a very good screening test other than this ratio. If you're looking at the data for those 4 screening tests, and if you think that the factor VIII is lower than the antigen, then it should sort of keep you in that, mode that I might be looking at a type 2N.
Either or.
Other than that, I'm not aware, but I'd be happy to learn from you.
Thank you, ma'am.
Just I may add 2 things for the clinicians. Therefore, it's very important because there is no single test which can be used as a screening, that you decide whom to investigate. Because once you decide that this patient needs investigations, he needs a thorough workup. Because then you cannot give up at the level of doing the routine tests. So the bleeding score was very, very important in discriminating which menorrhagia with epistaxis. I keep saying this because that is the huge chunk that comes to us. Epistaxis, 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 menorrhagia, menorrhagia, menorrhagia. The score tells you that this patient does not require investigation. You should rather go to the ENT specialist or a gynecologist. And the second thing is, of course, you have got research labs giving you molecular data on von Willebrand disease with the standalone labs today, with a turnaround time of just 1 week and at the cost of about 20 to 25,000, give you this information. As in other genetic diseases, a hematologist is now used to, these are lifelong diagnoses. So make use of the genetics. You just heard where it is required, where it is not required. So don't overdo it. but do it because this is a lifetime label for the person, and your treatment is based on that. And that treatment is to be decided by you at the time of diagnosis, which he has to carry for the rest of his life. So let that money be spent. Money spent on diagnosis is 1% of money you will spend on the treatment, especially on the wrong treatment, because that can take away your patient from this world. Okay, we move on to the second question. We'll take one from the audience now. Again, address to Dr. Jasmina. If desmopressin is not available, how do you diagnose type 1C?
Sorry, I didn't get the question, sir. How do you diagnose type 1?
If desmopressin is not available, how do you diagnose type 1C? 1C.
So if we don't have desmopressin available, then the alternative is the propeptide assay, which we have to do and take a ratio with the antigen. That is currently the way to find out if the type 1C von Willebrand disease is present or there is a clearance. But this is not 100% good test. The actual, the best test, which is recommended by the current guidelines, remains the desmopressin assay. And it's really sad to hear, sir, that if this drug is not available, I don't know what would be the clinical approach now to sorting this out.
Yeah, sure. We all end up with just factor replacement therapy. Okay, Bipin, your question.
Yes. So fantastic both lectures. Really enjoyed both the lectures, Jasmina ma'am and Agarwal sir. So I have just one question to Jasmina ma'am. So this is, am I audible, sir?
Of course.
Yeah. So I have just one question for Jasmina ma'am. Like this is particularly for type 3 VWD patients who develop inhibitors. Now, it is said that having negative test for one of the functional assays does not still rule out inhibitors. You have to go ahead and do all the functional assays, the mixing studies to rule out or to catch the inhibitor. Now, in our setup, it is not always practical and it is not feasible to do all the functional assays to catch the inhibitor. Now, we recently published one paper where we had two patients with type 3 patients with inhibitors. We published it in Frontiers. Now, fortunately, we did the recoff and we found the inhibitor in recoff. Now, if it was not there, then we would have had to do the collagen binding and so on and so forth, because the inhibitor could be against any functional or non-functional domain. Now, given the fact that it is not always feasible to do everything for every suspected patient, what would be your strategy? What is your experience, and what would you suggest? Like what strategy to adapt in such suspected cases?
Bipin, good question. I don't have too much hands-on experience on von Willebrand factor inhibitors. I had one case which really drove me nuts, and I've shared it at many places. But that was, we just saw that it improved over time, the factor levels, the von Willebrand factor levels, and we presumed that it was acquired von Willebrand disease. What I would say is, what do you want to achieve by, categorizing whether it is a collagen binding assay problem or is it a recoff assay problem? If you are not getting a good recovery after giving your concentrate, your 1 and 4 hour later recovery is poor, that means there is something which is leading to the loss of that von Willebrand factor antigen or the factor A, right? Something is either clearing it away or there's an antibody which is binding and removing it and making it non-functional. So I'm not sure what that question would, why would you want that dissection to be done? Why would you need to be very sure that it's a collagen binding assay, which I need to check? And once you get the titer, I presume the titer is important to decide how effective your therapy is, right? So even if we didn't do a titer, but we established that there was a inhibitor, and whatever management we did, if we were planning to give, rituximab or whatever else, immunosuppression or treat the disease and see what happens, a recovery of the factor, von Willebrand factor after the therapy would give us similar answers. Yeah. So I'm sure I haven't given you the answer that you're looking for, but I'm not sure how we would, how much that would help from the clinical point of view.
Yeah, this question was because the reduction, it could not be, it could be either absorption or it could be because of the presence of antibodies. So,
yes.
So if the patient is not responding, it could be the presence of inhibitors or it could be absorption. Now, if I say that I did the Rickoff mixing study and I did not find the inhibitor, I still cannot say with confidence that it is the patient is inhibitor negative. So in that case, I have to do other functional studies, and that's why this question came.
Okay, so if you have access to collagen binding assay, have you tried these kind of patients where have you tried that? Because these patients are not very common where you are going to have a severe von Willebrand who develops inhibitors. I don't think they're very common patients.
Yeah, it is not very common. But when they do come, we have to give an answer.
Yeah.
True. Thank you, ma'am.
Yeah, so as a clinician, we keep asking without realizing the difficulty of the lab in giving us an accurate answer. Unfortunately, in 80s, when we started practicing, we didn't have access to all this. The only simple way was that before you operate on a patient, do the desmopressin effect or give the factor and see the increments and then plan your surgery. So that was something which we do even today, rather than getting to the lab and asking about all this. The next question from the audience is from Dr. Thomas Kuncheria. He wants to know whether bleeding assessment tool is applicable to children.
There are some specific bleeding assessment tools for children. I think they're called pediatric bleeding questionnaires. I recall one by Dr. Paula James, and they are reasonably simpler. I probably look at epistaxis and cutaneous bleeds and bleeds related to trauma, with the scoring system going from -1 to 4. Again, somewhat styled like the ISTH pack, but yes, they are separate, and they have, the interesting bit is they cater to things which we won't ask in adults. For instance, umbilical cord bleeding, circumcision bleeding, and all that. So yes, there are separate bleeding scores for children.
Once again, I may just add a little that if the child has not been exposed to anything, then it becomes a little difficult to trust that score. And same thing can happen in elderly males. If he hasn't gone under any trauma, injury, surgery, procedure, and then to trust and say, because I just advocated that is what tells you whom to investigate. Now that kind of score can be low in this setup, and then if you decide not to investigate, sometimes as a clinician you can get into trouble. So we are very often more liberal from the lab test, and it bites the pocket of the patient quite a bit because you'll end up with a negative result most of the time. Anyway. So, Satish, your question.
Thank you, sir. It was just an extension of what you said right now. So we do see a lot of patients referred from gynecologists with puberty menorrhagia. And even if you apply the ISTH BAT score in menorrhagia, it comes to 3 to 4 points. 4 is the maximum, even if they require transfusion more than 12 months, 3 to 4 score. And they mentioned that the score should be more than 6 to be abnormal. And if they have not undergone any procedures and there is no significant family history, it becomes quite difficult applying these scores in these setups, especially ladies who come with puberty menorrhagia. So I wanted to ask you whether do you, once you rule out everything, if the screening tests are normal, do you recommend to evaluate for von Willebrand disease in most of these puberty menorrhagia patients who have more than 12 months requiring hormonal supplements?
Dr. Jasmina?
Most of the publications say that women are bearing the brunt of von Willebrand disease, and puberty menorrhagia and menorrhagia per se is the biggest presentation. Well, why aren't we seeing that so much? Probably we are not investigating for that. So if the other, we've ruled out the hormonal causes, we've ruled out the anatomical causes, I don't see what stops us from screening these children for von Willebrand disease. If we catch it, we at least have a diagnosis. If we don't, well, there may be another reason for it. And please remember, again, I'd like to emphasize that the target here must be to screen for von Willebrand disease and not just a basic coagulation score, which may just be normal in these individuals.
Yes, ma'am.
Sir, anything you'd like to add to that?
Not really exactly that is to be done, because this is a very, very common reference. And by the time a woman is referred by gynecologist to you and me, they have taken pains to rule out everything that fell in their territory. So having referred a patient to a hematologist, it becomes very, very important that you don't miss anything, because you're looking at genetic diseases If you miss today, somebody else is going to diagnose it tomorrow. And there can be treatment problems, there can be legal issues. So you do go into the depth of a woman who has got menorrhagia, which remains unexplained. And obviously only those menorrhagias are referred to you, which are a bit clinically significant. A little bit here and there, they are not sent to us. Same thing about epistaxis. When the ENT guy has not been able to help out the patient by packing, cauterization, then that child comes to you, or is bleeding from one side and bleeding from other side, then that patient is referred to you. If there is absolutely no family history, no past history, no other site history, it's one site bleeding disorder, I just tell them that the result is likely to be negative. These are expensive tests. You want to undergo, we should undergo, because this may be the only site of bleeding. That's the way to go. The family decides whether they can bear the expenses, because in private practice, they have to bear the expenses.
Right, sir. Thank you, sir. Thank you, ma'am.
Okay, so one more question from the audience is about, from Thomas again, 17-year-old boy, recurrent epistaxis, needing recurrent nasal packing, now has an excessive bleeding from a fall which lasted for more than 10 minutes. He has done the routine workup, the screening tests, which are all negative. There is no family history. Should he investigate this child for von Willebrand disease? Similar type of problem, I think, what we are discussing. Yeah, Jasmine.
Definitely, sir. If there is a bleeding disorder, which we are looking at, which has needed intervention, in children, we would say if you have more than 5 episodes of epistaxis in a year, that is sort of taken as relatively higher chances of having a bleeding disorder there, and getting a normal result as in the routine coagulation screen doesn't exclude von Willebrand disease at all. So I think this child, in my opinion, would need testing.
Right. So yeah, same, we already had a discussion, so we'll not repeat it. Only one thing, when you got a trauma and you bled for 10 minutes, that may not be a bleeder. Remember that, because sometimes you have lacerated a vessel, and that has happened. Sometimes we get these post-op patients for workup for coagulation, and nothing is found and nothing is working. They open and they find a bleeder there. So remember, when this trauma surgery, there may be a bleeder. Be careful. Dr. Mona, your question.
Yeah, good afternoon, ma'am. Excellent talk, sir and ma'am. So my question is that it states that von Willebrand factor is an acute phase reactant that increases in response to bleeding, sir. So ideally, how many days after a bleeding stops that we should go for a von Willebrand factor levels?
Testing?
Yes, ma'am. Von Willebrand factor testing, ma'am, because it might increase with the bleeding, acute bleeding.
Yes, it would. So I would say that you would need to, go through a couple of half-lives, that is at least 5 half-lives, to think that whatever increase has come up has gone, or you would like to think that the acute phase has settled and retest again, unless there's critical emergency. In severe hemophilia, in severe von Willebrand disease, there will be no increase because there is no von Willebrand factor there. Those are the situations where there will be a real crisis and you need to respond fast, even if there is ongoing bleeding. So there it won't be such an issue. But yes, in mild and these ones, it would be, you would need to just probably treat immediately with desmopressin or something to just increase the von Willebrand factor levels. And once the patient stabilizes, is out of acute phase, I would say maybe 7 or 10 days, then we retest again.
Okay, ma'am. Okay. Thank you, ma'am.
Thank you, Dr. Moda. We'll go one more question from the audience. Dr. Christopher has put a question. So you got a von Willebrand AG of 20 and RECOG of 12. The first question is whether this is type 2 or type 1. So antigenic is 20, RECOG is 12. Ratio is 60. Yeah, ratio is 60%.
Yes, so this is exactly one of the things highlighted in the algorithm currently. So if we go by the current guidelines, anything less than 0.7 should be taken as type 2 and more than 0.7 should be taken as type 1. But I would say in our setting again, that it's very important to retest once and reconfirm that both these values meant the same thing. The other thing is, it's not a very good idea to do just 2 tests, one antigen and one activity assay. in a type 1, we would expect all the, since it's a quantitative defect, we would expect all the other activity assays also to go down proportionately, which may not be obvious if you do just one activity assay, for instance, the recough assay. So if you really want to not miss a diagnosis and make a good, be sure of yourself when you're giving this, you need more tests in the lab to sort of clearly point out whether it is type 1 or type 2. Otherwise, a score less than 0.7 indicates it's a type 2 1 Willebrand disease. We would think that we might be overdiagnosing type 2, but there are further tests which we need to do, which will exclude this diagnosis in the step down testing. When we are doing the other tests and the ratios, we will be able to, confirm or negate a type 2. So I would think that this is more likely a type 2.
Thank you. Second part of his question is probably addressed to me. How much platelet should be given for treating a platelet type of von Willebrand disease? So yes, we do exactly what we do with all other patients who got platelet dysfunction. Here the count is obviously not going to help you. So 1 random donor platelet per 10 kg for a moderate bleeding episode. So for a 60 kg person, 6 random platelet or 1 single donor platelet. Then it depends upon your problem. You may have to double this dose or even triple this dose. You may have to give it once a day or you may have to give it twice a day. So this is just like somebody's platelet is not working, whether it's Glanzmann's, whether it is platelet type von Willebrand disease, and so on. Okay, Dr. Satish, your question.
Yes, sir. So this is regarding patients of VWD undergoing major surgeries. The first question is to ma'am, what parameters do you recommend to monitor before surgery? Factor 8 activity or recough or both to plan the treatment?
So from what I can see, that is there is some sort of different kind of information in different publications. Some of them say that you look at the factor 8 levels, and the others are saying that you bring the recough activity levels to about 50, or take them to 100 depending on the kind of surgery you're planning. So I'm not very good. I'm not very sure of what would be the best way to go about it. I'd ask Dr. Agarwal, what would you like to monitor your patients?
Satish, I was just reading the question in the question box. What was your question?
Sir, before any major surgery, what parameters should we monitor, sir, to plan the treatment? Should we monitor factor 8 activity or recough? And the second part was, after the surgery, what level do you maintain of both of them, sir? For the major surgery, I'm talking of major surgery like CNS or major GI surgeries.
A known case or unknown case?
Known case of severe VWD, sir. Known case of VWD.
If you got a known case, then guidelines are straightforward. I mean, I presume that there is no inhibitor. We'll remove that from the discussion. So on the day of surgery, for major surgery, you need to have the levels of 100%.
This is, you look at recough or factor 8, sir?
You look at both.
Both, okay.
You want both to be 100%. And then, depending upon the nature of surgery, for next 3 days to 7 days, you will like to have a level of 50%. These are nadir levels, drug levels. So 100 followed by 50. Same thing we do for cesarean section. And if you were there, I showed a chart. Depending upon the lesser and lesser intensity of surgery,
yes,
you can have 50 on day 1, maybe 25, 30 on the other days. For dental procedure, 1 dose is enough. For the routine vaginal delivery, 3 days may be okay. If you got PPH, you may go on to up to 5 to 7 days. So say you got a CABG or you got a neurosurgery, then 100% day 1. I'm little liberal, I keep 100% day 2, and then go down to recommended 50 from day 3.
Fair enough, sir. So we monitor both factor 8 and
you look at both, and because we are all using this, intermediate purity product, be very careful with that factor 8. It really amounts to 300% and 400%. So I'm giving them low molecular weight heparin.
Okay.
Because there is, you don't have an access to highly purified von Willebrand factor. And to have the recough of 100, you'll end up with factor 8 of 300.
Right, sir.
Because that is, staying in the body while the von Willebrand factor is getting destroyed. So when you get next day levels as 200, 300, 400, I don't cut down the supplements. I give them LMW heparin, give them stockings, the DVT stockings, and mobilize them.
Right. Thank you, sir.
Okay. The next question from the audience is there a role of platelet transfusion in von Willebrand disease? Yes, I mentioned in my talk, these are, anecdotal treatments. So unless you got a platelet type of von Willebrand disease, in standard von Willebrand disease, you are giving it as a source of von Willebrand factor. So these are all anecdotal cases, not as a regular treatment. Amrita Saraf, your question.
Thank you, sir. It was wonderful lectures by you and ma'am. And I think some of my answers are already, have been covered by the lecture. But still, I had a few queries. It's basically about the acquired von Willebrand disease. Like we know that in cases like, myeloproliferative neoplasm and lymphoproliferative disorders and sometimes cardiovascular events, this can happen. So what exactly should be the indication to go for a workup for acquired von Willebrand disease if we come across such kind of a condition? Or it just depends upon like when there is like, basically I want to know when should the clinician suspect it needs to be worked out?
So there are two, maybe Dr. Jasmine.
No, sir, you can go ahead, but what I understand is that definitely before any major surgery, if it is being planned, or if you want to put the patient on aspirin for thrombosis prophylaxis, because there, if he has acquired von Willebrand syndrome and you're going to give an antiplatelet agent, you may precipitate a bleeding event. So these are the two things I know of, but I think sir can tell us.
So, first is the patient has got von Willebrand disease. So you have done something, either a preoperative investigation, or for some reason you've done the workup and you found that there is a von Willebrand disease. That is one. The next is that why are you thinking of acquired? Because he was not a lifelong bleeder, and he has undergone insults in his early life where nothing happened. There are patients who have undergone a major surgery and nothing was happening to this person, and now the hemostatic workup is so grossly abnormal that you know that there is something which has happened now and it was not there before. So those become the patients where you investigate. Otherwise, in a routine case of a child or an adolescent or a woman with menorrhagia, this, that, you find von Willebrand disease, you presume that it is a genetic disease only. As you know, that aortic stenosis, there is a problem and they have a very high incidence of acquired von Willebrand disease. Monoclonal gammopathy, we just talked about. You mentioned about myeloproliferative, lymphoproliferative disorders, solid tumors. We had presented a case of SLE in a girl. So, you got some kind of background where you suspect that this could be an acquired secondary problem. That's how you suspect in clinical practice. And it is much, 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 much rarer than the genetic one.
Thank you, sir. So I have another question. Like how to interpret this von Willebrand factor and Rakoff ratio when the factor value is actually markedly raised. So how should we interpret in such a situation? It's for ma'am actually.
So what is your indication for looking at those values and trying to give a ratio? If it is, for an von Willebrand disease, we know that we can only make the diagnosis if the VWF antigen or activity is less than 30. So high VWF takes us out of that diagnostic range. If you're looking at acquired von Willebrand syndrome, sadly, we might still need to do it, I'm told, because you might have normal levels. So elevated levels are not really talked of in acquired von Willebrand syndrome, but you may have normal levels and yet the patient may bleed due to an acquired von Willebrand syndrome. So there you may have to, with the normal levels, you may try to get your ratio, you may do a ratio, but it really has no meaning in the inherited form, in the von Willebrand disease per se, because there you are supposed to have low von Willebrand.
Low levels, right.
So in this, they say that if you are suspecting acquired von Willebrand syndrome and you have higher levels of von Willebrand factor antigen and or activity, then you may need to actually look at the multimer pattern, because what we didn't discuss there was the multimers are in triplets. They look like a sandwich if you have a very good quality gel, and that pattern gets altered. So even that may be a clue that there is acquired von Willebrand disease and there is actually a problem with the von Willebrand factor, though not its levels directly. But you can imagine how very few would have access to this kind of facility.
Right.
But you can make a diagnosis of acquired von Willebrand syndrome in the face of normal von Willebrand factor activity and antigen levels. Yes, if there is a bleeding history and there is a ratios abnormal, then you can consider.
I understood.
Learn
Thank
the
you,
hard
ma'am.
way.
Just 2 days back, we got a case of SLE with, this angioedema and some alveolar hemorrhages, and we did the platelet function studies, and we did the correction also. There was partial correction, and we just thought, like, could it be, the required one? And maybe should we repeat in such a case, once the transient phase is over? What do you suggest? It was a 36-year-old female who was a known case of SLE and was referred for a platelet function study.
So in SLE, first I have to be very worried if there's a bleed to rule out hypoprothrombinemic and lupus anticoagulant syndrome. So I'm presuming that's already done and out of the way.
Right. No, it was done.
Yes, but I would like to test again. I would like.
Right. That's what we suggested. Thank you.
Sorry for that, Dr. Agarwal. Many times we just don't reach the diagnosis in one go, and we have to keep harassing our clinicians to give us another sample. It's really hard.
It's extremely important, actually. Next question from the audience. Dr. Arihant wants to know, for every case of moderate to severe hemophilia that you diagnose in your lab, how many patients of clinically significant von Willebrand disease are you diagnosing? So what's the ratio? A significant hemophilia, a significant von Willebrand. What's the ratio in your lab?
So because we don't get too many mild von Willebrand disease sent to us for workup, we obviously get only the severe ones, which represents just 5% of the entire von Willebrand load. So we are obviously diagnosing much less von Willebrand disease as compared to hemophilia. So in the hospital, if we are looking at 300 cases of bleeding in a year, maybe with about 80-90 of them would be hemophilia A, and I would say about 2 or 3 of hemophilia of von Willebrand disease, and most of them are likely to be the severe type. So very less, sadly being missed, I think. I hope that answers Arihant's question.
Yeah, I suppose so. Arihant is working in a hospital. We have a opposite picture in a private clinic where, all these girls and adolescent women keep walking in with bruising all the time. And we have to unnecessarily keep investigating, and then we keep finding either some platelet dysfunction or von Willebrand. And all these hemophilics, they go to Dr. Chandrakala. They don't come to us in the practice because they want replacement therapy more than anything. Dr. Harsha Prasad, your question.
So just before we go that, I'd like to also say one thing, that if there is a very high level of consanguinity in your population, then maybe you could get more of these disorders. In North India, this is not such an issue, so we probably are not seeing too many autosomal recessive presentations of von Willebrand disease. The autosomal dominants are anyway not coming in too much.
Sure. Yeah, Harsha.
Yeah. This regarding doing testing in cities where there are not in-house facilities for assessment for von Willebrand antigen as well as recough facilities are available. The question is, someone who has got O positive O blood group and has had transported sample, because many commercial labs, they do collect the samples in the cities and then transport it to the metros, and the result comes 24 to 36 hours later. And in those, there is a borderline low von Willebrand factor assay. So how do you interpret that, and what is your take on these transported sample? Usually we should do this test within a couple of hours after reaching the sample. So what do you think?
If the question is to me,
yes, yes.
Yes. So I am not a big advocate of, getting samples from outside, and I just don't encourage them in my lab, because we have seen such dramatic differences. We've seen patients who have had factor 8 and 9 both at 30%, and eventually when we test them, both are normal. So it can really mislead you. The only way I think we can be a little bit sure of what we are looking at is that if whoever is transporting the sample to a central lab is also sending a control sample alongside. So if there is a calibrator sample or something sample with a known value which is coming with the patient sample, and you have assessed you can see both that the control sample is giving a correct value, and you can then assume that probably this sample which you have got has also got the right value. But everywhere it is recommended that a fresh sample is best for von Willebrand disease. And remember, stress and exercise increase the levels. So even in the lab, when they come, we are supposed to tell them, please sit for half an hour before we take your sample. So I'm not sure whether that can be ever ensured, when you are getting a sample coming from somewhere outside. Pity, we need more labs which can do this testing, I think.
Thank you.
Situation.
Dr. Harsha, we have seen ample number of patients coming with a diagnosis of both bleeding disorder and thrombotic disorders, having extremely low levels which don't fit in your clinical picture. You feel there's non-bleeder and it's got a diagnosis of bleeder or thrombosis, and you feel it's a mild one and you find a level which is 000. All these are transportation errors. So because these are genetic disorders, you're talking about lifelong label, not very difficult for a family to travel once to a reference lab, give the sample, come back, and the reports can keep coming. So just a question of sparing 1 or 2 days, go to the lab, give the sample, and come back. That's the best way. I've had patients with antithrombin 3-0, protein C0, protein S0. Now, you don't want to make that diagnosis. Factor 8-0, factor 9-0.
That's true.
You straight away know that these are all transportation errors.
Thank you.
Okay, now going back to the audience. While giving desmopressin intranasal spray as a single dose before surgery, is fluid restriction required? If yes, how much fluid can be given and how frequently to monitor serum electrolytes? No, you do not need to do anything. No fluid restriction, no electrolyte monitoring if it's a single intranasal spray. This is recommended only if you are doing it for more than a day and more for children than for adults. We don't bother about the adults also. Dr. Harsha, you have another question? No. Okay, go to Dr. Rajat.
Good afternoon, ma'am. Thank you for the very wonderful lecture. Ma'am, first I would like to ask the role of APTT in von Willebrand disease, ma'am. If a patient has a symptoms of bleeding, ma'am, and his APTT is normal, would you further investigate this patient for von Willebrand disease?
So again, APTT is not always abnormal in patients with von Willebrand disease because it depends on the sensitivity of our APTT reagent which we are using in the lab. And most of us will use a moderate sensitivity APTT reagent so that we don't keep getting too many prolonged APTTs which we need to work up. So if I would not be at all surprised to find a patient with a normal APTT have von Willebrand disease. So if you're sure and your bleeding history is multiple bleeding episodes, you're talking about a young child or an older person, and you're looking at multiple site bleeding, as sir said, and multiple bleeds that need intervention, you may have a normal screening coagulogram, but you need to test for von Willebrand disease. Otherwise, you can miss it. That's why the panel is different.
Ma'am, if I put this question other way, because ma'am, in our center, we have really poor patients coming to us. So we try to do them the test at the minimum cost. So most of the time what we have done is I could put this question is other way around. A 4-year-old child with bleeding symptoms with a normal factor 8 level, ma'am. Would you consider this patient for the further evaluation of von Willebrand disease, or would you look for any other diagnosis, but not von Willebrand disease? Factor 8 is normal, ma'am.
So what about then the screening coagulogram? Why would one just do a factor 8? You need to look at the coagulation test if there is any other factor which is involved which could be responsible for the bleeding. But I think your question is, would you like to investigate for von Willebrand disease in this patient?
Yeah, von Willebrand disease.
If you have it in this patient. Well, epistaxis is a very common presentation of many bleeding disorders. So if I get a good family history, which is sort of suggesting a von Willebrand disease, yes, I would like to investigate. Otherwise, just by itself, epistaxis, unless it's really serious, I don't think. I mean, many people.
No, ma'am.
Yes.
So, Rajat, your question is.
No, ma'am.
Your question is if factor 8 is normal, whether von Willebrand disease will still be there, right?
Yes, you will have von Willebrand disease with the normal factor 8 levels. Now, not all von Willebrand disease will have abnormal factor 8 levels.
So you got your answer,
ma'am,
right?
which one? Yes. Some which von Willebrand disease will have a normal factor VIII level? Will like 2A, 2B, and 2M are like they are likely to have a normal factor VIII level and normal APTTs? Like, are they expected to have?
So if you're asking me very specifically, type 2N would of course have the lowest. The
Yes.
others may have a low factor VIII levels, but I can't offhand tell you that how many would have an absolutely normal factor VIII level. See, because if the factor VIII level is anything between 30 and 50%, we will say abnormal, but it doesn't prolong my APTT. So I wouldn't be able to pick it up. So
we will have to go for von Willebrand antigen. Like, so, can I?
Very suggestive. Yes, if your bleeding history is very suggestive, you have multiple site bleeding, and you have a family history, those things really help. Your DAT score would then really help, I would think.
Okay. Actually, the thing is, like what I am seeing is, we were like, you just told in your lecture that von Willebrand factor antigen level less than 30 units is considered to be von Willebrand disease.
Yes.
Yes. Like, I will like what we in practice do is like, if von Willebrand factor VIII level is less or abnormal.
So there is no diagnostic factor VIII level for any kind of von Willebrand disease, for that matter. In type 2N, it goes down very low, but there is no any cutoff level for factor VIII which says that this is von Willebrand disease if it is less than so much. This is not the identifying part of von Willebrand disease. It will have to come from the antigen binding and takeoff.
So antigen, if antigen is level, then I don't like my factor von Willebrand disease is confirmed. Then I have to do recoff and all those things to confirm the type of the assay. That is the thing you want to say, na?
So yeah, antigen as a standalone test will only help you in type 3, where it will be very, very low, unmeasurable. Then you probably may not need to even do other tests if you don't have them available. Though it's recommended you do everything. But if it's unmeasurable, you're looking at severe type 1 Willebrand disease. There you may not need to do anything else. But if you're not in the severe range, then you need to do the other tests to reach a proper diagnosis, whether it is type 1 or type 2, and if type 2, which type of type 2.
Okay. Sir, second question, can I move on to Dr. Agarwal, sir?
Go ahead. Can I just add
the
first question? If your factor VIII level is 70%, 80%, 100%, 110%, versus you've got a factor VIII level of 5%, 6%, 10%, 20%. So you don't want to discuss those cases. Those are all clear. Say you got a factor VIII level of 45%, 48%, 39%, and you don't do von Willebrand workup, you may still get patients who got von Willebrand, and the factor VIII was in this range of around 40-50%. So everything doesn't run parallel really. So you can't presume that their von Willebrand factor antigen and the functional assays all come normal.
Okay.
This will happen more in a mild bleed. Yeah, your second question to me. Yeah.
If it's at 70 and 80 Willebrand, if factor VIII is 70 in my first question, because we have been evaluating the patient like 70, would you not consider it as a von Willebrand type, right? If it's 80, let's say it's 80, factor VIII is 80. Okay, it's a difficult. It's okay, sir. Maybe I'm can get. Sir, secondly, sir, once I had a patient, sir, who was like a diagnosed case of type 3 von Willebrand disease. She was a female, sir. She was a 18 or 20-year-old female, and she wanted to get married. So she asked me like,
right?
Yes, sir, type 3, severe type 3, sir. She said that she wanted to get married.
Yeah.
Okay. So then what happened was, like, then she asked me like, how would it be pregnancy and how would it be the like marriage and all. So I was just afraid of this. Like, what do they need to? Are we prescribing any precautions to them? The hemophilia patients on von Willebrand patients, any precautions for the intercourse and all those things?
So you are quite okay in your question. You have to dissociate marriage from pregnancy. Number one, anybody can get married. That's not an issue. however serious
Okay.
you may have. It's a personal decision of the partner that he's okay with all these kind of things. And I don't think sexual intercourse will lead to that kind of bleeding or that frequency of bleeding that you will start giving prophylaxis for those, just that indication. The huge issue is of the pregnancy and delivery, which has to be at an institution with the total understanding that this patient will require replacements once a week or twice a week throughout first trimester, as well as during after the pregnancy of 34 to 36 weeks. And then you will have a significant requirement during delivery, vaginal or cesarean, and to prevent the postpartum. So that is a totally something which requires full management at an institution with a team of experts, with a lot of money required and the factor supplements required. So I'll dissociate marriage from pregnancy. And I don't think intercourse is going to be an issue that you need replacement of any type, even tranexamic acid. I will not recommend just like that.
Sure, sir. Sure, sir. Okay. Thank you, sir. Thank you very much.
Thank you. We go to the audience. Dr. Raj Warrior wants to know, is there a risk of hyponatremia? Is the risk of hyponatremia less when you use desmopressin by nasal spray? So, Dr. Raj, I do not know the answer to your question. If everything is related to the blood level of desmopressin, it should not differ. But yes, the absorption from nasal mucosa may not be that much as you do it with intravenous, and there may be a difference in the clinical practice. You may not get that much hyponatremia from nasal spray, but I'm guessing, I must say. I don't use nasal spray. I only have used intravenous. As such, we have shortage. We don't have that nasal spray available of the adequate dose. You also have another question. This is to Jasmina, I think. When you have antibodies, are these antibodies to factor 8 or von Willebrand factor? Alloantibodies when they develop in a von Willebrand disease patient.
So in type 3, they would be against the protein which is missing and you have replaced. So most likely the von Willebrand factor protein. In autoimmune diseases, there may be multiple antibodies directed against different coagulation factors. So you might just, in a patient of SAD, you might have both. You might have antibodies against von Willebrand factor as well as against factor. So I would think the setting in which we are thinking about where the antibodies would, for what we are giving the replacement and we are anticipating the antibodies to come up, maybe that would see what they would be directed against. Whichever is the foreign protein, the antibody usually comes up against that in an allo setting, but in auto, it's absolutely against anything.
Right. He has one more question, which I will answer. Is the risk of myocardial infarction less in patients who have low von Willebrand factor? So I distinctly remember post-mortem studies of atherosclerosis being looked in patients who had von Willebrand disease, and it was significantly less. So I only remember that kind of post-mortem study. Whether in clinical studies there is a data showing less ischemic heart disease, I am not sure. You have specifically asked for mild von Willebrand disease. I'll have to search the literature to answer this question. Dr. Asha Shah, your question. You are muted. Asha, you are muted.
Yeah. As you sir already have highlighted, menorrhagia as well as pregnancy are the most difficult parts to manage in a patient with von Willebrand disease. My question was, of course, it is very difficult even for a patient with severe von Willebrand disease to get pregnant. How do you manage her during the pregnancy? As you said, if we might have to replace factor, von Willebrand factor. Again, the levels of von Willebrand factor as well as factor 8 are not very reliable during pregnancy because they can rise. And whether if in India, if we have only the ones with factor 8 and von Willebrand factor. So if the factor 8 levels also become high, then the risk of thrombosis, would that also need to be addressed?
Okay, so Dr. Asha, number one, when you're talking about pregnant women and prophylactic replacement, you're giving it once or twice in a week. So this issue of factor 8 going up, etc., is not a clinical issue. Second, whatever we discussed just a few minutes ago was only for type 3, where you give factor once or twice in a week during first trimester to prevent miscarriage. And then you give it from the 34th or 36th week onwards, because at any time the woman could go into labor and deliver, and you cover the whole of delivery or cesarean or the epidural. In fact, epidural is contraindicated in type 3. And then the next about 5 to 7 days after the delivery. All the discussion which I did of prophylaxis was basically for type 3. When you got other type of von Willebrand disease, then you look at the increments that are taking place because of the pregnancy itself. I showed you some curves, how with the advanced pregnancy, the levels go up. Most of these women, they do not need anything. You just take care of the delivery part, vaginal or cesarean section. And if they are keen on epidural, then we give support to them. And all these are just 1 or 2 doses, so you don't have to really worry about factor 8 increment or risk of thrombosis.
So even when you are giving it in the during the delivery, just before delivery and after in the postpartum period?
Yeah, so you're just making it reach about say 100% for a cesarean or 50% for a vaginal delivery, and then going to stop it in next 2, 3, 4 days. I don't think the factor 8 levels have gone up in that setting for me. What I've seen, these 200, 300, 400% factor 8 levels are when you have to give it for a long period. You're giving it for 7 days, or you're giving it for some event has occurred, especially the accidents, and where something keeps surgeon keeps doing something, and you're giving replacement for a long period. But during normal delivery of cesarean section followed by 3 to 5 days of prevention of PPH, factor 8 is not an issue.
Sir, and one more about epidural at the time of delivery. How would you give it, and for how long? Sir?
It's ideally contraindicated for type 3. In rest of the condition, you just push the level to 100%. 1 dose is enough.
And while removing the epidural catheter, sir?
So we have not really looked at that time. We have allowed them to remove the catheter. Again, I'll have to look at the literature, but at that time it is recommended to give the factor.
Thank you, sir.
Thank you. Dr. Amrita, your question.
I just thought of a question. It's about, like, we know that in hypothyroidism, the factor levels go down, but somehow, and we know like how common it is, especially in females, but we never consider it while interpreting the values. So is it like whenever we are analyzing the levels of von Willebrand factor, should we consider how much is the thyroid levels, or like a thyroid profile should be considered? I mean, in terms of while it can affect, underestimate the levels.
Question to me?
Yeah, Dr. Jasmina, go ahead, because
yeah,
I blank at this. I have never looked at this at all, so I'm 0.
Okay.
I just thought about it, like, will it affect, because we never, even see how much is the thyroid level, or how is the thyroid profile.
Same here. So clinically, we don't do this. So I have no information.
So you're not alone in that. Everybody, nobody would do it. But it's a good thing that if you have seen abnormal levels of von Willebrand factor, and there is no good clear-cut family history, and it's not looking like a very severe von Willebrand disease, the testing profile is not looking like that, then this should be asked to be excluded, because I think it's pretty common in our part of the country, and it's a cause of bleeding. Hypothyroidism is a cause of bleeding.
It can.
And it gives rise to an increase in platelet count. There's a reflex increase in platelet count. Those platelets may absorb von Willebrand factor and give rise to a very acquired von Willebrand syndrome. So there are n things that can happen. And if we think about it, we would probably look at the data and also question. I'm not so sure how much it would help in males, but in females, I would definitely want this thing to be investigated. It's such a common disorder. If this is the way we are going to catch it, what fun.
Because many a times, they are on altroxin or something, and then once the level comes low, maybe then we can have an eye like if it is like controlled or it's not.
But then you need access to the patient again before you sign out your report, or you just add a line at the bottom, please look at the thyroid levels.
Right, maybe as a comment so that the clinician can, correlate it if they have a value with them. Thank you, ma'am.
Thank you. We have some
Thank you, sir.
from the audience. What is the role of PFA 100 for von Willebrand disease?
So PFA 100 seems to be a very good modality to screen for von Willebrand disease, but not for the mild type, not for type 1. It seems to have a good sensitivity for type 2A, B, M, and type 3, but not for type 1. The other thing we have to be careful about for PFA 100 is that it's affected by the platelet count and it's affected by the hematocrit. So in patients, like in our country, there'll be a lot of patients who have anemia. We have to interpret it with caution. And in patients with type 2B von Willebrand disease, where there is a low platelet count, again, we would have not be sure of our results. But otherwise, there is literature to say that it is quite a good screening tool. And I think recently there's a publication from Vellore where they're using the PFA 100 for screening for carriers of von Willebrand disease.
Screening for carriers of
von Willebrand disease, like the carriers of von Willebrand, parents, mothers of children with von Willebrand disease.
So
severe von Willebrand disease, their mothers or.
All right. Dr. Arihant wants to know, like hemophilia, if you have patients who are on regular prophylaxis in von Willebrand, receiving plasma-derived concentrates, do they develop inhibitors with the same frequency as in hemophilia? Any information, Dr. Jasmine?
No, sir, not for me. I don't have any.
Nothing from me either. We do not have patients on regular prophylaxis of von Willebrand. I would say most of the patients that we see in practice of von Willebrand are type 1, because as I said, they just walk in with small problem. Type 3 are a very, very small number. So I was very curious when I saw the AIMS data that was published that type 3 is so much. But that institution probably get the most severe bleeding disorders. So it's a question of pattern of reference. So I don't have an answer. From experience, I don't have an answer to your question. Dr. Babita Sodi has the next question. Okay, just a compliment, Dr. Jasmina. Okay. So there's no question there from. Thank you so much for the compliments. Dr. Richa wants to know, can you summarize the lab diagnosis of acquired von Willebrand disease syndrome?
So in the lab diagnosis of acquired von Willebrand disease, the first thing would be to get a history if there is a secondary cause for the abnormal bleeding or for the abnormal tests. So in our setup, we get a lot of requests for myeloproliferative neoplasms with high platelet count where this is suspected. So that is one situation. As sir has already said, monoclonal gammopathies may be associated with antibodies that get directed against the von Willebrand factor molecule. Acquired von Willebrand disease may be as a result of our hypothyroidism. So we need to exclude those. So if you have, it's very important to know the setting in which you're getting it. And after that, we need to do the entire panel and see that your antigen is low, your activity levels are low, and just make it as a acquired deficiency. There is no need to really further categorize it into type 1 acquired pattern like acquired von Willebrand disease, or type 2 like pattern, or type 3 like pattern, because I don't think that has any bearing. But just the abnormalities in the test can sort of suffice. And as I said before, I learned this from after talking to a couple of people that you can even have normal levels, but if there is a setting of bleeding, you can still have an acquired von Willebrand syndrome, provided the multimers show some abnormality.
I can just add as a clinician that these patients are a headache in management. We don't have, though I showed you a flow chart, but when it comes to the clinics, and if the patient has active bleeding, post-surgical, post-accident, or patient is for surgery, it's a nightmare really. We do not know what will work. We have used intravenous gamma globulin, rituximab, corticosteroids. In long term, we have used MMF, and often the results are dismal. So if the primary disease is curable, wonderful. The primary disease is not clear or it is not curable, these are very, very bad patients from the angle of prognosis when they've got overt clinical bleeding. Dr. Radhika wants to know, how do you counsel a young von Willebrand disease who wants to get married? I think we just answered this question. So it won't be very different from what Satish had asked. Dr. Babita Sodi, is your approach for pediatric von Willebrand disease different, Dr. Jasmina? A neonate who has got low levels of von Willebrand factor?
For the diagnosis, not really, sir, because I said we are a little bit fortunate. Unlike the other vitamin K dependent factors, von Willebrand factor levels are normal at birth, virtually normal at birth. So, you know, if you have a deficiency, you can follow the same workup that you're doing in adults. But where you are sort of, you know, for the screening bit, of course, you need the bleeding assessment tool, which will help you to get, you know, with how many sites of bleeding there are and how severe is the bleeding and whether you should investigate or not. But once you're on the track that you want to investigate the patient, then the same tests, there is no difference.
Second part, Vita has asked, how do you manage such cases? No difference whatsoever. We manage in the same way. Dr. Warrior has just suggested that you should rule out angiofibroma in young adolescent boys. Thank you so much. And the last question from Dr. Richa Juneja is, how to interpret variant of uncertain significance in von Willebrand factor gene with normal lab in a child who has epistaxis?
You're probably asking the wrong person. I don't have too much experience in the genetics, but I think you would need to follow the same thing, which you would do for other variants of uncertain significance, you know. Wait till you have more people with the same genetic defect. Look at the parents. If they are symptomatic and they have the same defect, then maybe you would get a clue that it might be probably pathogenic. Not yet, but sometime later. Or you do a validation study or a functional assay to, you know, confirm that. But before that, of course, whatever you get in the NGS, you need to, you know, confirm on your Sanger sequencing to make sure it's the same thing there. Check the parents. If they're both normal and this thing is just there, then it might just be a variant of uncertain significance. But other than that, I'm not the best person to answer this question.
From a clinician angle, I can only request the clinicians to ask for NGS panels for any disease only if you feel it's going to make a difference in the diagnosis of treatment. Don't just ask for the asking sake, because you have not been able to diagnose somebody. This is not a diagnostic test really from that angle. So a starting point should be very strong, like we talked about type 1. So be very careful. This applies a lot to oncology because a lot of mess is happening all around. Few more questions have come up. Dr. Siaram, how much risk of thromboembolism due to raise factor 8 during pregnancy? So pregnancy is a prothrombotic disorder. You will end up with the DVT and cortical venous thrombosis, the highest incidences during pregnancy. So pregnancy is a prothrombotic disease, depending upon, as you know, thrombosis is a multifactorial business. If the lady has got a carrier state for, say, factor 5 laden, or she's got underlying lupus anticoagulant, or she's protein C deficient, she will have a higher problem. But just without any genetic or acquired predisposition, pregnancy per se, or the oral contraceptive pills per se, or hormonal replacement therapy per se are thrombogenic. And you get clinical cases off and on. Now the last question, I suppose, is Dr. Chikodi. What is the role of ADAMTS13 in von Willebrand disease?
In von Willebrand disease?
Yeah.
In the disease per se, I don't think it would be having much of a role, because when we have a problem with ADAMTS13, it raises the von Willebrand factor levels and increases the ultra-large multimers of von Willebrand factor, leading to thrombosis, predisposing to microthrombi and that kind of a thing. So I'm not sure whether ADAMTS13 measurements will have anything to do with von Willebrand disease.
Right. Jasmina, are you okay taking for a few more questions?
Oh, yes, sir. Please go ahead. I'm learning.
Dr. Rajat Jain has put question in the chat box. 4-year-old male with recurrent epistaxis. Did we answer this already? 4-year-old male, recurrent epistaxis, normal APTT. Will you consider von Willebrand disease as your differential diagnosis? I think we've answered this. 2-year-old child with bleeding symptoms and normal factor 8. Will you do von Willebrand disease workup? We have answered this. Yeah, that was the only question in the chat box. So that's the end of questions. Anything over here? The faculty that is present here? If nothing, then on my behalf, I thank Professor Jasmina Ahluwalia for spending such a long number of hours educating all of us. I'm sure the audience has benefited tremendously. Dr. Jasmina, your audience from 30 countries who have logged in for your lecture today. And,
that's your audience, sir.
But they have come because you are the speaker. Anyway, we come to now the vote of thanks from Ashutosh. Everybody's hungry. Ashutosh.
Yeah. Thank you, sir. Thank you, Professor Dr. Jasmina, as well as to you, sir, for the wonderful presentation. Thanks to all the discussants as well as participants for sparing your valuable time this Sunday afternoon. Thanks to Mice Ideas for flawless execution of the program. Lastly, I once again like to reiterate that in our philanthropic endeavor, we ensure that no patient is denied of the treatment because of the cost factor. So in our unique drug support program, we support all non-affordable patients across the country within 24 hours once you place the request to our sales team member. Hence, you can be rest assured when you prescribe any of our brands. Thank you so very much. Good day.
And one major charitable work we are doing is supporting our educational activities. From 30 countries, if there are doctors who are educated, you can imagine that 30,000 patients will be having a better care tomorrow. So thank you so much.
Sir. Thank you, sir.
Thank you.
Thank you.
Bye-bye to everybody. Have a wonderful lunch.
Thank you, sir. Thank you, ma'am. Thank you, everyone.